Good morning, councillors, officers who are attending this morning, any members of the public who are out there watching us. Welcome to the People and Health Scrutiny Committee meeting of the 31st of October 2023. If I can introduce myself, I am Jill Taylor and I'm the chair of this committee. As we go around, if I can ask members before they speak if they can introduce themselves, because basically when people are online, they don't know who we are and it's quite hard to distinguish. Could I also ask officers and guests that we've got here today, when they speak, to also introduce themselves and the job title? Thank you. So if we can start the meeting today with apologies. Do we have any apologies, George?
We have no apologies from committee members, but Councillor Somper, the portfolio holder for adult social care, health and housing, has given apologies. Okay, thank you very much. Could I have any declarations of interest, please, from the committee? Councillor Ireland.
Yeah, Councillor Ireland, representing Crossworths Board. I'm a Governor of Dorset Healthcare, appointed by this council.
Thank you. As we go through the agenda, if anybody realises that they do have a declaration of interest, they can add it at the time. Can we go to the minutes of the last meeting, please? Can I approve these as an accurate record of the meeting? Or, yeah, and a vote for that, please. Thank you very much. And I'll sign those in a minute. Have we got any members of the public for the public participation part?
No, there's no public participation.
Thank you. And have we got any questions from councillors?
And there were no questions from councillors received.
Thank you. I haven't got a slot for chairman's announcements, but I am going to just make a couple of announcements that I think will be quite useful to the committee. We've had a few meetings since the last committee that I think it's well worth reporting back. We're trying, as you're well aware, a new way of working, so a lot of our work will be done in informal meetings and then reporting back to this group. We were asked if we would like to talk to the UHD, the University Hospitals Dorset NHS Foundation Trust, for an update on what is happening over in the BCP area, and to give us a chance to look at how it will affect our residents in Dorset. It was a really, really useful meeting, actually. It was an informal committee meeting, and we had officers from over there, and they gave us an update on mainly their building works, and I think they've got about a £250 million programme going on in that area, which will affect our residents in Dorset. They talked about the new building work that's being done at the Royal Bournemouth Hospital and the new beach building, which I think I've got this right. It's births, emergencies, critical care, and children's health, which basically brings a lot of sections together under one roof. That is going really well, and they're intending to open that relatively soon. They also talked about the Pool Hospital and consolidated planned care that's going to happen over there. That will also retain an accident and emergency. And they also talked about the changes that they're going to be making to Christchurch Hospital. It was really interesting because we discussed it as to how it was going to affect Dorset Council. And we talked quite a bit about staffing and whether this was going to affect our staff in our area. And we were given assurances that it shouldn't, because they're not actually increasing numbers of staff. They're improving the facilities, but their numbers of staff are remaining fairly static. The other main issue that we discussed was about transport, because obviously some of our residents are going to have to travel over there for healthcare. Certainly there will be people going to the Royal Bournemouth Hospital for acute care, which they are now very well aware of, and the need to facilitate transport for our residents to make sure they can get there. And this is joined up transport. We talked about train stations and you can get to the train station and then you're stuck because you can't get to the hospital. And the importance of having visitors, the importance of having family around people when they are very ill. So they are seriously looking at this and looking at how all this can be improved. It was a really good meeting, and that was a really good format for a way forward for this committee, because we can only do so much during committee time. So these sort of things, if we can move them to informal meetings and then report back, I think this is going to be the way forward for this committee, rather than call in a lot more meetings. The other person that we've met that's been really interesting, Councillor Rennie and myself had a discussion with Louise Betts, who is from Dorset Health Watch. I did actually forward a paper from Health Watch to everyone on dentistry yesterday. You've had this one before, but I thought it might be quite useful with dentistry being on the agenda again today. They do a lot of what I would call really deep dive scrutiny work. They go out and do a lot of work with the public to find out what the public actually think of their services. As such, they're very aligned with what we do. They are hoping to attend our meetings in the future, and I'd very much welcome them here, because partnership working is what it's all about. We can only do so much as a committee. So if we can use other groups, work with them and help them as much as they can help us, I think that would be really useful. There is an ICB meeting going on at the moment, so they're actually at the ICB meeting, but I'm sure ours was timetabled first. So hopefully next time we'll see them, and they will be taking part, obviously as non-voting members, but I'll welcome their presence. The other thing I did just want to mention, you may have noticed that you've got the Dorset Centre of Excellence Safe Forward Plan on our agenda this time. I may have wondered why that has suddenly popped in. I've been having discussions with Jonathan Mayer, and both of the shareholder boards, both this one and Care Dorset, are effectively cabinets of this council. Because they are cabinets, we can possibly do call-ins. I will say we need to be exceedingly careful on what we look at, what we do, because this will only involve any decisions that are made by our council that affect those boards. So we cannot call anything in on their day-to-day running, that they are independent companies, they are basically independent, and we shouldn't be looking at that. But where we make decisions as councillors that affect them, then we can call that in. Okay, so we've only got the one on the agenda. The Care Dorset hadn't got a forward plan. They have to publish a forward plan 28 days before the meetings, as they do with all other forward plans. And there isn't a meeting within 28 days. Therefore, I haven't got that on the agenda for today. But I just thought I'd fill you in on that as to why that is now appearing on our agenda. Councillor Kimber.
Thank you, Chair. Councillor Paul Kimber, Portland Ward. Within the last, I wonder if you can advise me, Chair, and I've listened to everything tentatively as to what you've said, and I'm pleased that you raised the problem of transport, because that for a resident in my area, we had to organise, and it was very, very easy to organise, and they were very good to come and pick up and take that particular service user to the Bournemouth Hospital. But on another issue, in the last 24 hours, we've had a very difficulty with the Portland Hospital. We had a development group. We just about had everybody on it, and his dog. Unfortunately, it seems to have been, we seem to have been waylaid. Now, could I put an item at a future meeting on that for us to look at?
Is this the minor injury unit that was on Portland, or?
Is a key aim of ours, obviously, to get the MIU back to Portland. We it's not only for Portland, it's for the residents of Wyke and Rodwell. So it was a very needed facility for our organisation, but unfortunately we've had to, they've cancelled a meeting, and it looks like they've completely cancelled it, where almost the development group is written out. So I would like to try and put this onto a future agenda to see what help that we as a scrutiny committee can have a look at.
Okay, if we can take this offline and we'll talk about it later. There is actually a really interesting paper that Healthwatch have just done on the minor injuries units and other emergency care. But if we can talk about this later, Paul, and we'll also bring George in on it and see what we can do. Okay, thank you.
So I think my third meeting. Thank you.
Thank you. Right, if we can go on with the main agenda then. First on our agenda today is the Safeguarding Adults Board annual report. Sorry, I've just missed urgent items. Do you know, I couldn't do this without George. Urgent items. Do we have any urgent items? Thank you.
Your vice chairman was useless as well.
And my vice chairman was useless, as she's just said. We have this system of kicking under the table. Right, so now we're going to go to the item on the Safeguarding Adults Board. We should have, hopefully, Sian, oh gosh, do apologise, Sian Walker-McAllister online this morning. She is the independent chair of the Safeguarding Adult Board. If I can just say before we start, this is a joint board with BCP. So the report that you've got before us this morning has got quite a lot of information on BCP, but if we can just concentrate on the DC areas of the report. I will say that it is an independent board, and that is really important. This paper has already gone to Health and Wellbeing Board and is for noting, but is also for comment. So if I can hand over to Sian, and thank you, Sian, for coming this morning. If I can hand over to you now for a presentation. Thank you.
Thank you very much, Chair, and thank you, councillors, for inviting me to your meeting this morning. So I'm presenting to you my second annual report as the independent chair of the Safeguarding Adults Board. So I'm appointed by the board, although technically I'm paid for by contributions from the council. I am independent, and I hold Dorset Council, BCP Council, the NHS and the police and all other public sector bodies and voluntary and community sector to account for delivering effective safeguarding across our area. So if I can go to my first slide, George, are these up? Because I can't see them on the screen. No, that's not it. And colleagues, I thought it might be helpful. You've seen the report. I know you will have read it with interest. I just thought it would be helpful to have a few slides pulled up so that I can just take you through the key salient points. Thank you. Thank you. So if we can go to the next slide, please. Thanks. So the board has three key statutory duties. We're set up under the auspices of the Care Act, and the Care Act defines those three statutory duties: to develop and publish our strategic plan, setting out how we meet our objectives and how our members and partner agencies will contribute. And this annual report details what we've done and how effective we've been. We also have responsibility to commission, undertake a safeguarding adults review if somebody has died or experienced significant harm and that person has care and support needs, and it appears that agencies have not worked effectively together. So I will be talking, and the report shows that we published one safeguarding adult review this year. We have others in train, so it's not only the one that we've delivered, and they will be published within this current year. So this annual report takes us up to the end of March 2023. So I'm reporting retrospectively to you. My statutory duties require me to report to the Health and Wellbeing Board, as Councillor Taylor mentioned earlier. We haven't yet been to the Health and Wellbeing Board. We will be doing so in the next month or so. And we are also more than willing to report to scrutiny committees, to cabinet, to other boards, the NHS Integrated Care Board, to police boards, etc., as required. But the one statutory duty is the Health and Wellbeing Board. And you have mention of Health Watch attending this committee earlier. One of our requirements is that we send our annual report to Health Watch for scrutiny and comment prior to our board approving and finally agreeing publication of the annual report. And that was received by Health Watch and noted, and they didn't have any comments to make on the report. Next slide, please. So this slide just sets out the data which we published within the report relating to Dorset Council. Now, can I again be absolutely clear that I don't just hold Dorset Council to account for delivering safeguarding, but all other partners as well. But within adult safeguarding, the local authority is the lead statutory body, and it will be the local authority that appoints the chair, ensures that the Care Act delivers against all its safeguarding requirements in respect of the board, and collects all the data. So safeguarding concerns, some of you call them referrals, the technical term is concerns, are referred in to adult social care. And adult social care then make decisions as to whether they meet the criteria as defined under the Care Act, or whether they need referral on for a different response, which might be a response from adult social care. For example, a Care Act assessment to undertake and detail whether the person has care and support needs that need to be delivered, or it may be that the matter is referred to one of the voluntary and community sector agencies that work in partnership with the council to provide support. The Care Act is very, very specific, and it defines people having care and support needs who, because of those care and support needs, are unable to protect themselves from abuse, from neglect or harm. The data sets out here the numbers of concerns received, the numbers of concerns that are referred onwards for other activity to ensure that the person remains safe, and that data is collected in detail by Dorset. It's differently collected in BCP, and in fact, I work nationally and see this data up and down the country. It's differently collected by adult social care and councils up and down the country. And there's been a lot of work by NHS Digital to try and get a much clearer definition, but it's not always possible to benchmark why Dorset has this number of concerns and why BCP has that number of concerns, for example. So the data is useful because it helps provide pointers. It helps us to identify themes that the board needs to look into. So if we look at some of the data, we can see that many of the concerns have come in from service providers, and that's social care service providers. And you might say, oh, well, that's really concerning. Actually, I am not concerned, because what that's showing me, and having dug down into that data with colleagues in Dorset Council Adult Social Care, is that we know that's reflective on the relationship that exists between the council that commissions those social care providers and those providers themselves. They feel comfortable to report concerns when something has gone awry. And it's not always an act of omission that results in a safeguarding concern being referred. It may be, of course, it may be a medication error. It may be that somebody's had a fall. It may be a whole number of issues that happen to individuals who are living with considerable amounts of risk. But what that data is showing me is that there is good engagement from service providers. And I triangulate that by going out to meet with service providers at their regular meetings that they hold with Dorset Council, and getting a sense of how they understand and can report safeguarding concerns, and how also when there are concerns that go on to be an inquiry, so a more detailed investigation, how they respond to the findings of that inquiry. Concerns and inquiries are carried out by adult social care and not by the board. But the board reviews those statistics and understands and gets a picture of where it needs to undertake audit, do some deep dives, get a real sense of what's happening on the ground in terms of protecting Dorset residents from abuse and from neglect and harm. You'll notice the outcome of the inquiries, where risk removed was 32%. I'm not overly concerned about that. Risk reduced was 66%. I think that's good, and that's the sort of outcome you can expect. I'm often asked questions, well, how can we stop this from happening totally? How can we ensure that there is no risk? Well, you'll be aware, of course, that we can't ensure that. Adults have the right to undertake in risky activity, and we can't always remove it, particularly where they have capacity to take unwise decisions around their lives and around how they engage with or don't engage with services. So I think overall, in terms of the outcomes, I'm really happy as the independent chair in terms of the data that's presented. We know in terms of gender and age that women and older people are more likely to be subject to safeguarding intervention, partially because women live longer, and more women than men are living and receiving support by some of our care providers, and partially because of the societal impacts on women as a whole. You will know last year that we presented SAR Catherine, and we did a lot of work on SAR Catherine with our colleagues in the Community Safety Partnership, with the Domestic Abuse Organisation, in terms of learning how an older woman who suffered domestic abuse died, and the learning that emanated from that Safeguarding Adult Review. So this year we have been conducting several Safeguarding Adult Reviews across the piece. We've taken one SAR Simon to our board this year, but it's not yet published, and when it is published we'll be reporting on that in this current annual report. We published one Safeguarding Adult Review last year that wasn't in the Dorset Council area. SAR Aziza, a student who ended her own life, a student at Bournemouth Arts University who ended her own life. So I'll move on to the next slide. I'm sure you will have read some of the detail from the report before seeing this slide today. What I wanted to set out next was our strategic plan. So this report, this annual report is 2022 to 23, and what's up before you now on the screen is our strategic plan for that period. We revised the strategic plan in March 2023 at our annual board development event, and we've refined it under 3 key headings to try and make sure we're much more succinct in expressing and communicating the important issues that we need to deliver. But the issues there, all contained within the annual report, are how we've delivered over the last couple of years since I've been the independent chair. Many of these issues also translate into ongoing work for this current year. Next slide, please. So the next two slides actually are just setting out some of our achievements during 22-23. And you've seen these in the report, but I just wanted to highlight them as I think they're really important. So there's been considerable work with our community engagement subgroup. This was a group I established when I was appointed as independent chair. And it's been really important to ensure we communicate wider than just officers working in across all our partnership, and we include people's experience, and we represent the voice of somebody. We determine the unheard person, people who commonly won't come forward, but we work with the voluntary and community sector to make sure that we listen to those voices. Indeed, we've got a piece of work going on in this current financial year and next, where we're revising our website, and we're going to be working with a small subgroup of the CEG to ensure that it's easy to understand, it communicates well, and that people in communities can understand where to get information on our website. So that's a piece of work that we're doing. We've been doing some work with that group around carers, and those are informal family carers and their understanding of safeguarding. As a result of Sarah Ziza, we started work with staff from the higher and further education establishments to widen communication around safeguarding. We've commenced engagement with the registered social housing provider sector, known as registered providers. You'll sometimes hear them referred to as RPs, and faith groups. We've published 7-minute learning papers. These are so good, you know, because they reduce the complexity and ensure that staff who work in busy areas on the front line have a easy to understand perspective on those two issues, understanding homelessness and exercising professional curiosity, because those are issues that come out of safeguarding adult reviews nationally and locally and regionally. We've worked alongside Dorset Healthcare Forum. We've delivered Learning at Safeguarding Adults Week. We've delivered an information pack for board members, and that's all about ensuring we're all on the same page together. And very importantly, we commenced work with the chairs of the Pan Dorset Safeguarding Children Partnership and both community safety partnerships. And as a group of chairs and senior officers, we meet quarterly to share information. And what's really important there is that we ensure that we don't duplicate, that we learn from one another, and where statutory processes cross over, for example, a domestic homicide could potentially also be a safeguarding adult review. We undertake one review, and that's important from the person and the family member's perspective, but it's also important to make sure we work efficiently together and again on the same page. And I've talked before about our reflective development event. The next page, please. So Sarah Ziza I've mentioned, and that's been published with an action plan. That was a SAR that was undertaken, a safeguarding adult review across the BCP council area. We've delivered our training strategy. In children's safeguarding, they are required to deliver training across the partnership. We are not required to do that in adult safeguarding. But what we do is have a strategy where we're very clear with agencies what levels of training we expect them to deliver. And we hold those agencies, those partner agencies, to account for delivering that training. And we'll be doing that as part of our annual event in March this year, reflecting back on the year and looking at how effective training has been to improve outcomes for people. We've reviewed our board business arrangements. We have commenced a lot of work refining the data that we get. You saw the data page earlier, but NHS Dorset have a new information system known as DICE, where we're able to, no pun intended, dissect and look at information in our areas, so that we're looking from a perspective of place of where we might need to concentrate safeguarding activity, understand why safeguarding activity occurs more frequently in one area as opposed to another, for example. And that work is ongoing, but by the end of this year, we shall have a refined data set that will help us understand and better and improve the work that we do. So we're all for continuous improvement. We updated policies and protocols. We've improved our board member engagement. And as I mentioned earlier, we work outside of the board as well. So I'm not in favour of just bringing more and more people onto the board to be on the board to discuss things, because it can become unwieldy. I'm in favour of working outside the board as its independent chair with different partnerships. We've been working with housing providers, working with the prisons, working with a number of other organisations, faith groups, for example, to see how we can spread our communication and make a difference. We've undertaken an audit of what we call making safeguarding personal, and I'll just define that for you all. It's basically around ensuring that for every safeguarding intervention, we find out what the person would want out of that intervention in order to feel that they are better safeguarded and better involved. And if the person is unable to make those decisions for themselves because they lack capacity, then we will work with advocates and or with family members to make sure that we understand the decisions they would have made if they were able to do so. And we're strengthening making safeguarding personal, the acronym MSP, through training and development, and we focused on it at our board development event in March last year. Next slide, please. So some key messages I just want to end with. So I hold all partners to account for delivering effective safeguarding strategies and services, and on the same page is my group of words that I use to make sure that we are all joining it together, because it can be very complex when there are many different boards covering many different issues. My mission in life is to make the complex simple, and therefore joining it together is important. We work across the partnership to ensure it continuously improves, and in particular to ensure we share data and information and understand challenges. The board has enabled a focus on joining up across the system, and I've already given you examples of how that works. We've been currently in this year looking at right person, right time, which is a new way the police will be working, so that they're involved essentially only in policing work, but work better with partners to support those people for whom the police often intervene, and where there might be other more appropriate interventions. And we're working to develop our approach across Dorset in a cooperative and collaborative way. And much of the work that I've described is still in train this year. And just important to note again that we are strategically engaged with the other statutory partnerships. And that's all I want to say, and I'm happy to take questions.
Thank you very much, Sian. That was a really interesting presentation you've given us, and certainly the notes that we've got here are really interesting. If I can go for questions now, I think I've got Councillor Kimber first. Thank you.
Thank you, Chair. Councillor Paul Kimber, Portland. Thank you for a really good presentation. One of the things I find as a ward councillor, when I'm dealing with the health authorities, at times it feels like a mountain to climb to find the right person to contact. And I welcome some of the comments you made regarding that you're trying to reach people, and that for me can only be applauded. Can you tell me how you actually reach the ordinary man in the street that may be finding it very, very, very difficult to raise concerns with you? And I'm pleased that you spoke about social housing or RPs, housing providers. So if I can address that question, how can someone contact you? And I say this quite deliberately because my work as a councillor at times, it used to be sort of general council things, but it's more and more I'm getting people worried about they can't get their operation that they need. Thank you. If you can give me that point.
Thank you. So in terms of, we won't be so concerned about around people getting their operations on time. They know they need to access all of that information via their GP. That isn't specifically a safeguarding concern unless it's somebody with care and support needs who may have been forgotten in the system. What we're very clear on our website that if anybody has any safeguarding concern at all, so if something doesn't feel right in the gut, I can't express it to you physically, but you know what I mean. If something doesn't feel right about someone, for example, if it's an older person and you see lots of younger people going in and out of their house, or that aren't related, and I think that perhaps they're being cuckooed or abused by younger people in a community who might not be up to good intent, then you should report that to the Adult Social Care Contact Centre, and we have the number on our website, and Claire will put it up in the chat. I haven't got the number on my papers at the moment with me, but anyone can contact and they will have the opportunity to discuss the concern, and then the concern will be acted upon. Importantly, why we go out to people wider than just the statutory partners on the board, as you expressed, is because the more people we can talk to about safeguarding and how to refer, the better. So recently I went, it was in Bournemouth, but I shall be doing the same in Dorset, to meet a group of GPs in one of their learning events, just to talk through the safeguarding process and to identify any glitches that were happening, because people weren't sure where they might report safeguarding concerns to, or what they should expect when they report them and how they should receive feedback. So those are the sorts of things we're doing all the time. The safeguarding team who work within Dorset Council are ace at reporting and passing on their contact details and ensuring that council officers from wider than just adult social care understand what safeguarding is and how to report it, as well as going out to community groups and presentations in community halls, etc. So we can never do enough. We always have to carry on because people change and new people come on scene, and we will carry on doing that. Communicate is the order of the day.
Okay, thank you very much. Councillor Ridout, please.
Thank you, Chairman. Councillor Belinda Ridout, Gillingham Ward. A brilliant report, Sian. Very, very detailed and quite an eye-opener for me for some of these figures. And I note there was a quote of 101 concerns reported each week. That might be due to the success of your campaign for safeguarding and getting the word out there, which is great. I'm just querying about the data collection. You mentioned this DIS system, Dorset Insights and Intelligence System, and you're developing this. So will all data from all the partners you work with feed into this system? Will, like the police, DWP, the Fire and Rescue Service, will eventually all that come into one system so we have all the data? And when would that likely to be completed?
Okay, thank you. So the DICE system is NHS Dorset initiated, and that enables us to have the overlay so that we can be clear. So, for example, in areas of social deprivation, we know it's likely that we'll have more safeguarding concerns. It's likely that there will be more fire and rescue activity. It's likely that there'll be more criminal activity, and it enables us to begin to sort of dive down into that data. Police data is notoriously difficult to get in relation to adult safeguarding because the National College of Policing hasn't yet refined its work in terms of how it trains officers on adult safeguarding, and often they talk about vulnerable adults. They did a report a few years ago on older people, and that was everyone over 55, so I would be included in that as well, even though I'm not vulnerable and I wouldn't necessarily have a safeguarding need. So what we're working on with the police is making sure that they are aware locally of the definitions around adult safeguarding and can report as necessary. But having the DICE data enables us to map it all out, and it enables us to make sense of it. So that's what we're pulling together. And it, in our quality assurance subgroup, which works with the data analysts from across the partnership to bring all that data together, they can then deep dive and think, actually, for example, the first councillor, Paul Kimber, who asked a question from Portland, and we know that in Portland and the Weymouth area, there's greater social deprivation than in other parts of Dorset. So we can begin to start analysing, and we can ensure that the teams of people who are working in that area can look out for particular areas of activity and be able to highlight and recognise when certain actions are needing to be taken. So getting the data right, not just for data's sake, but to enable us to, as a board, strategise and plan with our partners to ensure that they're working in the right place at the right time with the right people.
Okay, you're happy with that? Councillor Orrell.
Thank you, Chairman. Councillor Orrell, Melcombe Regis, which is Weymouth Town Centre. So my questions are going to be about housing. I will end with a question. I congratulate you on your work over the last year. It's very important to have an integrating board that gets agencies to work together, and particularly to target some of the active harm to children with physical or sexual abuse. It needs interagency working. My thoughts around the neglect aspect of safeguarding, and some of the root cause of that seems to me to be housing and homelessness. I looked through the report last night and then did a word search on housing, homeless, and it shot through the report, understandably, some of the case histories, some of the actions needed. And that's what we've found in this committee over the last few years, is whenever we look into a problem deeply, we find housing is actually at the root of a lot of it. And I congratulate you on page 15. That's been recognised, and it looks like in 23-24 you're going to be working with the housing strategy that's emerging from this council, because we're not going to be able to solve some of these problems of neglect unless we get housing sorted. So getting to the question then, how many cases of safeguarding, particularly around neglect, do you think would be solved if we as a council were able to engineer decent traditional council housing, something that's low cost, warm, properly insulated, with good communities? How much of this neglect could we ameliorate? Thank you.
Okay, so thank you. So just to refresh you, this is about adult safeguarding and not children's safeguarding. Working with housing partners is really important because as we do so, we're able to provide those working on the front line in housing with information to enable them to identify concerns. Whilst I absolutely concur with you that that there is a housing shortage and that homelessness impacts on people who self-neglect, what's also important to recognise is that those who self-neglect often do so not just, they are homeless because of their trauma and their experience and issues that affect them personally, as well as the lack of housing. And self-neglect isn't just an outcome of lack of appropriate housing. So I'm perhaps not explaining this clearly enough. So often people who self-neglect have experienced significant trauma in their lives, either as children or earlier as adults. And what's really important is that we ensure that those who are working with them understand that and take an approach which is one of supporting them to engage more proactively with the supports that are on offer. There has in the past been nationally a number of safeguarding adult reviews commissioned of people who've died who are homeless. And some of the issues that have come out from those safeguarding adult reviews, so this is not local, this is national, have been describing homelessness as a lifestyle choice. And we know that's entirely wrong, and it's not a lifestyle choice, but is often as a result of trauma or experiences of individuals that, we all hear that we're potentially all 3 months ahead of, 3 months away from homelessness if our circumstances change. So it's about changing hearts and minds within safeguarding and across the whole of the public sector and the voluntary and community sector, and amongst citizens, that people who are homeless absolutely have needs for care and support as a rule. You probably find that about 80% of people who are homeless have mental health needs. So what we're needing is, I think, more specialist housing, more supported housing, and the funding of that, of course, needs to come from various sources. So working with social housing providers across the county is really, really important, because it helps them understand when they're strategizing and planning for their developments, the sorts of development that they need to take on board. And we work very closely with Andrew Billany and his team. And Andrew has always been incredibly supportive of the Safeguarding Board and our agenda, and attends and contributes to that to make sure that we're, again, all on the same page. So yes, it would be lovely if there were more housing resources and supported housing resources, and of course that will make a difference. But importantly, it's about how we engage with those people who are homeless and experiencing homelessness to ensure that they don't slip off the edge, that they're not on the edge of care, that they are very much central to the services that can be supported, and that we are proactively finding the right way to engage with people.
Thank you, Sian. Your timing is absolutely amazing, because as you were talking about Andrew Billany, he walked into the room.
I didn't see that.
So welcome, Andrew. Just on this, I find it interesting on this committee that so many things come back to housing and the quality of housing, and time again, the shortage of housing, and how difficult it is to increase or seems to be difficult to increase the amount of housing that we have in Dorset that is affordable for people. So looking at, as you mentioned, social housing, I think is really, really important. And we need to release the land to build, to make more housing. And I'm sure Andrew Billany will say yes, but as he's missed the majority of this conversation, he's probably not going to comment. But thank you very much for those comments. Is that okay, Councillor Orrell? Okay. Could I go over to... I'm going to go to Councillor Rennie next, and then I've got a non-committee member who would like to ask a question. Thank you.
Hello, Councillor Molly Rennie, Vice Chairman of this committee. I'm just going to say this because the context is important around my questions. I'm Chair of the Domestic Abuse Forum, and very nice to see Sian here again today. I was going to pick up on the homelessness and the issue around that, so that's been really interesting and useful, and it was pleasing to see Andrew come in as the words were being said. We were told at the last Domestic Abuse Forum by Sam, one of our housing officers, by Sam Brand, that there are some housing that's going to come into force for women who are homeless, who are or have experienced domestic abuse. And when I read on page 24 Paul's story, I thought how important this question of housing is and how complex it is when somebody has a safeguarding need in any form whatsoever. And it is important that we recognise this need. We sometimes sort of I think I'm losing the plot a little bit. We sometimes lose the understanding that without that house and the roof over our heads, all the other things that we do as a council perhaps pale into insignificance if we can't help them within a place that they feel safe and secure. I wanted to congratulate Sian and her board on this report. I see much as what she spoke about last year, her desire for partnership working and the increase in that. And I wanted to ask her if she feels that it is happening, because she mentioned earlier on about we've got to do this continually because staff changes all the time, organisations change and charities change, and it's about this continual training and this need to do this so everybody's learning points are all at the same place continually and we don't lose the message. Thought that was very important when she spoke about knowing how a person wants to be contacted and is able to be contacted, because so often when you review cases, you find that that contact's fallen apart because they didn't pick up on a new telephone number for somebody or how somebody had asked about what their choices were. And I feel that that theme is running throughout the whole of the report about partnership working and how crucial it is within this work. Thank you as well. You gave me a really good idea. On page 19, you talked about the work within the NHS. And I know that they have ISVAs for domestic abuse. And I thought, bring this all together. We'll have a presentation at the forum. So thank you for giving me that idea as well, Sian. This is really positive, but I wanted to ask, as well as a final question, if Sian, she talked about what she's done, but I wanted to ask her if she was pleased with what's happened this year with the work of the board. And it met the expectation. She's smiling, so she must be. But has it met the expectations?
Thank you very much, Councillor Rennie. And yes, I am pleased. You know, I don't like boards for boards' sakes. And I don't like... you know, we've done that, so we've ticked that box and it's on the shelf now. I like to continually revisit things, to be asking the and so what question, because at the end of the day, it's only as important as what we're currently doing and how we're currently able to communicate with people. So what I'm pleased about are the way we've kind of reached out, the way we're working, and the way our community engagement group's developing. I'm pleased with the way we're engaging with housing providers, not just the strategy people in the local authorities, but we're going out beyond that. I'm pleased with the way our relationships developed with a new integrated care board. And I'm pleased also that we challenge each other in the board. So it's not just nice, cosy, we all sit and agree with one another. We challenge one another and hold each other to account. And that's very, very important. And the one final thing I would like to say is that, you know, safeguarding boards aren't just about reporting what's happened. Ultimately, our main responsibility is around ensuring that all partners prevent and work in the best way they can to prevent. That means getting in early, it means recognising what to do, it means escalating if they've referred something and they haven't heard anything. And that's why communication is so important, and that's why you never give up on communication, you just carry on doing it, because as you said, you know, people change and we need to make sure that happens. And one other thing, we talk about contextual safeguarding. I know it's a bit of social work jargon, so forgive me for that. But what contextual safeguarding is about is the context of the person and what's important to them. And you know, if the person who has the best relationship with somebody is the sheltered housing officer, or is the person from the fire brigade who comes in to do the safe and well check and installs the alarm, let them be the person who starts the conversation, who starts to understand, who starts to recognise. If it's the contractor that goes in the housing association house to do the CP12 gas check and notices something that's not right, how do we make sure that they know where to report it and where to go and how we pick things up from there? So it's about thinking, I think, taking our our important hats off as board chairs and the rest of it, and thinking, how would it be for us if we were living in this situation, or we were working in this situation, and what would we need to do? And so I will continually to ask that question, to press for making the complex simple, and to ensure that we try not to miss things. Having said that, we will miss things. Things do get missed. Awful things happen, but we need to do our best to make sure that there's learning from that. And that's the purpose of the board, to address those in its safeguarding adult reviews.
Thank you. Okay. Thank you very much. Can I now go to, we've got a non-committee member here, Councillor David Taylor, if you'd like to ask your question.
Thank you, Chair. Thank you, Vice Chair. I'm Councillor David Taylor from Chelmsford St Mary Ward. I'm particularly interested in basically on the last conversation we've just been having, but there was a couple of questions from before. The deep dive that you're doing with mental health issues regarding the housing issues and housing authorities and separate authorities looking after housing. Are we looking into the fact that we have families in houses, for example, like 2 parents, 4 children in a 2-bedroom house? The mental health of the mother is not well, and it's just the fact we need to look at these things to see whether or not we're identifying it through the housing associations, because it's not been identified. There is another family as well in similar circumstances, and also the fact of surprises like rent increases, which not for this one today, but have suddenly been increased and not been informed, which have caused some major problems throughout the housing stock in Dorset and Dorset. My final question, which is referring to the question sheet from before, not the last sheet, you showed the one before, I kind of caught the comment was the fact that we are not in responsibility for training adults for safeguarding. Have I heard that correctly, or should it be addressed in another part? I may have misheard that.
Okay, thank you very much, Councillor. So in terms of your questions around housing, they need to be referred to your housing officers within Dorset Council. Where I'm concerned is if there is a safeguarding issue, that housing officers on the front line are recognising that and are working with us to do what needs to be doing. And I think that's important. It's about recognising when there is a safeguarding need and when that may need to be addressed by a variety of actions. So and we get that, and that's why we housing are proactively working with the board, and we are working proactively with Dorset Council housing and officers and registered providers. In relation to training, the point I was making that in the statutory duties of a safeguarding children partnership are to provide training. It is not a statutory duty for the Safeguarding Adult Board, which has considerably less funding, by the way, to provide training. However, if we notice that there's a theme coming up that we think it would be helpful for the board to take overarching responsibility for overseeing, facilitating a piece of training, we will do that. So our training strategy sets out what we expect all our partners to provide in terms of basic training, and we mark their homework. We will look at that. We'll ask the question, the and so what questions, what differences this has made. If you say you've done that training, why is X, Y, and Z happening, etc., etc. So we'll triangulate that, and we'll do that in the work of the board. What we've recognised through learning from safeguarding inquiries and through learning from safeguarding adult reviews locally, regionally and nationally is that there needs to be greater learning on the application of the multi-agency risk management procedures. So we have commissioned what we call MARM training, multi-agency risk management training, and we will be overseeing that and have an expectation that all our partners will ensure that their staff at the appropriate level attend that. And in particular, it's that recognition that it's not just council staff's responsibility to call a MARM meeting. it is anyone's responsibility. It could be the police, the ambulance service, the fire service, the probation service, the prison service, and I could go on with other partners as well. So that's what we're doing. And then we will look back on that and review after the year, what difference has that training made? Have we had more MARM meetings? What has been the interface between MARM and safeguarding concerns, inquiries and safeguarding adult reviews? Has there been a difference? Thank you.
Thank you. Is that okay? Brilliant. Okay. I've just got a couple of questions, which I'll call these as the last questions, as I've got no other people on my list. My questions, one is basically around the staffing that you've got for to administer the reviews and the calls and all the rest of it. You said among these papers that your calls have increased by 25%. And I know we discussed yesterday that your staff haven't increased to be able to do this. Are there any plans to either increase staff or look at different ways of working to make it easier for the staff? Because some of these must be quite harrowing that come in. And staff need support, and it's easy to cut the time that they have for support rather than because there's frontline work needing to be done. And it's just really a welfare question about the support for the staff and how difficult it is for them to be working with a 25% increase in the calls coming in. That's my first question. And my second question is around the action plans that result from the SARS and how well they are embedded into organisations. Because quite often you find that a piece of training is done, things change short term and then they go backwards. It's the embedding the training that is as important as actually doing the training. And I just wondered if you could explain how the embedding part of it is done. Thank you.
Thank you, Councillor Toes. So in terms of staffing, that's a question that needs to be with adult social care, because it's not the board's staffing that receive these safeguarding adult concerns. It's actually adult social care. But before, perhaps, if I may also say, so where the board gets involved is where it recognises that there are issues that need responses. So the board is overseeing at the moment, and there's a task and finish group ongoing, development of a cross-organisational adult safeguarding supervision strategy. And that's ensuring that every partner organisation has embedded, and we will seek assurance that that is the case, a proper support strategy for staff in terms of improving practice on the front line in safeguarding and ensuring that there's the right support for staff so that they're able to exercise their professional curiosity. In terms of learning from safeguarding adult reviews, every year we undertake, we have a special event, it runs at different times of the year, where we review all the local SARs over the last 3 to 5 years, regional and national SARs that chime in with those as well. And we ask, would it happen again? And so what, and what have we learned? And as part of that process, we will also ensure that we check on organisations' delivery against the action plan for learning on a SAR. I said earlier that I don't like doing stuff and putting it up on the shelf and saying that box is ticked. We will revisit those issues, and we have an event planned for this year.
Thank you very much. That is really assuring. Can I just go? I've got an officer in the room, and I do apologise. I don't know what your name is, but she's just offered to comment on the staffing levels.
That's okay. I'm Julia Ingram. I'm the new Corporate Director for Adult Social Care Operations, so I'm not surprised you might not be familiar with my name. I just really wanted to reassure the committee that we take the well-being of our staff extremely seriously. As part of our CQC assurance in May, we undertook a independent safeguarding audit, which examined the breadth of the work we deliver as part of our safeguarding responsibilities. And we've delivered from that audit, or we put together a very clear action plan, which includes a scrutiny around whether we're organised in the right way to manage the capacity and demand that we've got coming through. But we also have a number of measures that make sure that we look after our staff. There is routine training. Each of them receives individual supervision. We also have a number of practice forums where we examine critical cases to make sure that they're understood. And some of those are overseen by our principal social worker and our principal occupational therapy, where we examine risk and accountability. We run a number of learning events and, as I say, routine team meetings where all of those issues are examined. So we take, as I say, very seriously the well-being, but we're also examining the demand we've got through and whether we are organised in the best way to manage that. I hope that's helpful.
And may I add, Councillor Taylor, that assurance is provided to the board as well?
Thank you very much. That assurance is really welcome, because at Dorset Council we value very much our staff, and we take pride in looking after them. So thank you very much for those assurances.
Could I just say something there? And I think what was really important when I wrote it down, when Sian said our safeguarding team are ace, I think that that value, to hear that adds to the value that they will feel as well.
Thank you for that comment. Right, we're going to the recommendations now, and the recommendation, as I said earlier, is to note this report. I don't normally take papers for noting, however, these safeguarding reports that we have are for noting only. But I think we've had a really good discussion on them and a really sort of very broad, wide-ranging discussion. And I thank you very much, Sian, for coming today. Just before we go to a vote on this, which I don't think we need to vote, do we, George? No, we don't. Could I just comment that something that might be useful, talking of training, is training in the adults and children's safeguarding boards for new councillors next year. We have a new council from May, and there'll be quite a large training programme. And I think it would be quite useful if there's a conversation as to whether it would be possible to run a training event so that councillors can understand what these boards do, the work of them, and how important they all are. If you'd be agreeable with that, Sian, and I'll put you in touch with our training. Okay, if you're okay with that, Sian, George has said he'll take it away.
Yes, and thank you. We've provided safeguarding masterclasses for members before in not only in this area, but now the other areas where I've chaired. So I'm really willing to do that. It'd be an absolute pleasure to do that with officers.
Thank you very much. We get safeguarding training, but it's what the board actually does is I find really fascinating. Okay, so we can note that paper. We don't need a vote for it. And thank you very much, Sian. And we'll move on to the next paper. Let me just flip my bits of paper. Thank you so much.
Thank you.
Right. If we can go on to our next agenda item 8, which is an update on the dental services and commissioning. We looked at dentistry a few months ago as a result of concerns that we had coming in from residents about the lack of dentist services in Dorset. Residents had been contacting us, and really sort of looking at the statistics, we could see at the time that there is a lack of NHS dentists in Dorset. And we wanted to have some understanding as to why that was happening and what measures were being put in place. We asked for an update of it, and I think it's quite timely that we have an update now. So we've invited along, I've forgotten his name, I'm terribly sorry, do apologise. I have a piece of paper with your name on somewhere.
Yes, that would be lovely.
Sorry, we've invited along Robert Payne, who is the Deputy Director of Strategic Commissioning, to come and talk to us this morning. He's going to give a short presentation, and then we'll open the debate on the paper that you have before you. Thank you. If I can hand over to Robert.
Really, thank you, Chair. I can hear myself, so hopefully that means everybody can hear me. First of all, thank you very much for the invitation today. Really looking forward to the discussions that we're going to have. I've brought my colleague along from the ICB, Matt Baker. Matt will introduce himself further on in the presentation, and also Tess Fielding, who's from our regional collaborative commissioning hub team. She's joining us online today. Just by way of background, it's worth just noting that we work as part of the Southwest Group through what's called Managed Clinical Network. So the context of how we work in Dorset with Southwest is really important. So I'm really pleased that Tess has come along to support these discussions today. We'd also hoped that a regional clinical lead called Matt Jarrett was going to be able to join us. He can't, but he's really keen to work with us. He also links in with health overview groups across Southwest. So we're thinking about how we can, take that sort of joint approach about looking at this across the Southwest area as well. So a brief presentation, and then happy to take any questions from you. Next slide, please. I'm just going to do a quick context and background setting, and then Matt's going to take through further detail around the current level of performance and access, which, as you know, is very challenging, but it's really important that we're open with you today to share some of those challenges. And then Tess is going to take through some of the risks, but hopefully also some of the opportunities moving forward for us to work together. And then I'm just going to briefly conclude with what some of the emerging priorities are on this work. The first slide really is just to confirm that as an integrated care system, we are now responsible for what I call the four high street primary care contractor groups. So that's general practice, pharmacy, optometry, and dentistry. It's a really important context because for the first time, we're actually bringing those four contractor groups together to work together through our governance structure as well. And from next month, they will meet together formally for the first time, because we strongly believe that the future is about integrating care and working together. We've already heard in your committee today how important those relationships are and understanding our population health needs. So we're really keen to bring those contractor groups together, working in local communities with you and other partners on the future of population health. Just I would mention at this point as well, actually, that I've also been speaking to Louise Spate from Health Watch. Louise and Health Watch are a really important part of our system. So we commissioned some of the work that Health Watch did around dental access, because we need to understand that. And we are going to propose to this committee and also the BCP Health Overview in future meetings. It's really helpful, I think, for us to perhaps come together to share some of the work the Health Watch is doing, and we can just have that really joined up conversation about how we work together moving forward. So that's certainly our intentions to do that. Next slide, please. You've probably seen this slide before, but just to remind us all about the purposes of our integrated care system. I mean, it is very much around working together around population health. We know there's a lot of work to be done around understanding and addressing inequalities, and that's really important in relation to dental access and oral health as well. It's also value for money is an important part of this, and productivity, because it's a finite budget and the needs just increase. So it's really important to look at that, and also to recognise that the broader determinants of health as well. So really keen to work with you on that, and we're already working closely with your public health leaders as well about how we work together on this. Next slide, please. Again, just in terms of context setting, I think it's fair to say that we'll probably never have enough dentists. And we'll never have enough public funding to do what we want to do. I would love to be able to say that there will be a time in the near future where we'll all have easy access to high street NHS dentistry. Sadly, I believe that may not be the case. And I think that's partly because we need to understand the wider determinants of oral health and oral health inequality. And this has been recognised nationally by our Chief Dental Officer. So our work is not just on dental access, it's about understanding oral health and what we can do, how we can work with partners across the system and how we can commission improved oral health so that the dental workforce and dental profession and dental access that we've got can be targeted to maximise the benefit to population health. Next slide, please. The other thing I just wanted to highlight is the importance around targeting care around oral access and dental health. And this, again, has been recognised nationally around work on addressing inequalities. And this core 20+5, again, you colleagues may have seen this already, but just to highlight that it does identify oral health as a key priority within tackling population health and inequality. And locally, we are keen to particularly address how it impacts on children and young people so that we can help children and young people to make the best possible start in life. And oral health we see as an important part of that work. Next slide, please. So this is the final slide by way of introduction, then I'm going to pass to Matt. It's really just to say that we recognise dental access and oral health as a really high priority in Dorset, and I hope you share with us in that ambition around making it a priority for how we work together moving forward. I just wanted to highlight really that we are seeing a lot of risk to what I'm calling our high street primary care services. So that's across general practice, pharmacy, optom and dental. So while we're focusing on dental today, why I'm so keen for them to work together is we want to make sure that their services are sustainable. And we believe one of the ways they will be sustainable is about working together in local communities. So hopefully this is the start of the journey around how we do more work together around bringing those services together around population health needs. I think it's fair to say that the dental profession has been struggling to recruit workforce over more than a decade, and they've also been very unhappy with their national contracts. So we are taking on responsibility for commissioning at an interesting time. So it's a real challenge. But we have a great ambition to work with you on improving access and oral health. And there is a real opportunity because we've got a very good collaborative across the Southwest, working together across 7 ICBs. And as we've heard from previous speakers as well, we've got some really good relationships building across our integrated care system. So I think we're in a good place really for that collaborative effort that's going to be needed moving forward. Just finally, by way of introduction, there is something called a dental reform strategy nationally and regionally. And our early work in Dorset since taking on delegated responsibility from April this year is that we concur with the ambitions, particularly around oral health, around supporting the dental workforce, to developing our dental workforce, and that will then contribute to our dental access. We see really good alignment with our integrated care system strategy around making Dorset the healthiest place to live, and I think it aligns very well with our ambitions and our 5 pillars around doing this work. Thank you. I'm going to hand over to Matt now.
Thanks, Rob. Can you hear me? Apologies in advance. I'm getting over a cold, so I'm a little bit croaky. My name is Matt Baker, Principal Lead for Primary Care at NHS Dorset. I'm just going to provide a bit of an overview and some scene setting around the current dental provision we've got in Dorset and the Dorset Council area. On this slide, you'll briefly see there's kind of 3 settings that we recognise dental care to be provided. Primary care, secondary care and community services. Many of us in this room and our constituents will recognise the primary care or the high street dentistry. Much of this presentation and the paper we provided focuses around our high street dentists services. Just very briefly, the dental provision on our high streets are provided by independent businesses operating under an NHS contract. Many of those, as you will know, will offer private dentistry services as well. All contract holders employ their own staff and provide their own premises, and there is some reimbursement for part of their contract on their premises. There is some domiciliary treatment as well under the NHS contract. and the commissioned using what we call dental units of dental activity, UDAs, and UDAs is the currency that I'll talk on the next slide, please. So courses of treatment, I won't go through all of this slide, but essentially any activity that's undertaken within NHS dentistry is measured in units of dental activity. Some of us who do fortunately have a NHS dentist will know that, you know, if we go for a checkup, that's many of those treatments that are covered under band 1 there. The next band there we've got is, you know, bit more complex activity, so root canal work, removal of teeth, some fillings, and then we go on to band 3, which is the most complex work that's taken on in our high streets. And then there is also units of dental activity for emergency care within NHS dental practices as well. Next slide, please. So in terms of setting the scene for Dorset, there's 121 contractors currently delivering primary care services in our high streets. And you'll see there just a quick comparator between 21 and 22 and 22, 23. You'll see that we've seen a slight decrease in the amount of UDAs commissioned in Dorset, but a slight increase in value. So we're looking at, for dentistry for the whole of Dorset, and I'm talking Dorset and BCP here, we're looking at the region of £40 million commission for high street dentistry. Next slide, please. Quite a busy slide here, but it goes back all the way to 2017, 2018, which details essentially the amount of UDAs we contracted in Dorset, all the way through to 22, 23. The levels of UDAs contracted have been more or less the same. You'll see that there's some movement around there, but obviously the main area there we're focusing on is the amount of UDAs that have actually been delivered with NHS dentistry is significantly reduced, particularly post-COVID. However, we have started to see an increase in activity within dentistry, and you'll see that on the left-hand side there that we estimate to be complete around 66% of contracted levels by the end of this financial year up to March 24. And just to note there that the contracts around orthodontic activity are currently overperforming, and we're looking at around 101% of the target by March 24. Next slide, please. Just a bit of context here in terms of where we are in Dorset compared to our other South West colleagues. As Rob mentioned earlier, much of the dental service provision has been commissioned as a South West basis, and it's only since April this year that Dorset ICB have taken responsibility for dentistry and optometry and high street pharmacy. You'll see there that we're very much on par in terms of the other 6 systems in the South West. And as I alluded to previously, we have seen a slight increase in access for adults and children, access in dentistry. And as at 30th of June 22, 36.6% of adults in the county have accessed NHS dentistry, and around 45.8% of children have accessed NHS dentistry. So for Dorset, it's just above the South West and just below the England levels, and children, it's about the same as the South West and just below the England levels. Next slide, please. In terms of the latest data for Dorset, so you see we've got the adult and child population there. We are looking at the moment around 41% of adults will be accessing NHS dentistry in this current financial year and over the last 24 months, and 53% of the children's population accessing NHS dentistry. I'd like to pass on to my colleague Tess, who's actually online. Tess, hello, can you hear us?
Hello, yeah, I can hear you. Can you all hear me?
Yes.
I can hear you. You can hear me, yeah, okay. Thank you, Matt and Rob. So my name's Tess Fielding. I'm a programme manager, formerly from NHS England, looking after the dental contracts across Dorset in primary, secondary and community care. I now work in what's called the Collaborative Commissioning Hub. So we work alongside our ACB colleagues, still looking after the contracts and being the expert in the room, if you like, on some of the contracting. So we can just go to the next slide, please. So just wanted to talk a little bit about, and Rob and Matt have touched on this already, but some of the challenges that are currently within the practices to deliver on their contracts. There are specific workforce challenges right across the board, and this is where potentially not training enough dentists, or training dentists that are then diverting directly into private work. That's the high street. In terms of secondary and community, these are dentists that have more enhanced skills, so they may be specialists or consultants in their own area of expertise. And again, those training pathways take quite a long time to establish, and it's that sort of continual churn of the workforce that is an issue. We're still facing post-COVID recovery. Primary care dental practices are still dealing with a backlog, and I know that's quite a long time ago now. It feels like a long time ago now, but the backlog is still there, and there's still quite a lot of work that needs to be done to address the fact that the practices were closed for a significant amount of time. So we are concerned that the needs are going to rise. So this is one of the things that the managed clinical networks are looking at right now. A lot of patients not having access to dental care means that there are more problems building for the future. So again, the managed clinical networks are working through that. And I think Rob touched on this as well. This is around the one of the real risks to NHS dentistry is the sustainability of the business model. As we said, they are independent business owners. They own their own premises or rent or lease their premises. They pay all of the running costs. The only contribution towards the cost is a percentage of their business rates. Everything else has to come out of the money that they receive for their contract to deliver NHS dental services. We are hearing more and more about the cost of living increase for dental practices, where electricity charges, for example, are going up beyond the annual rise on their contracts. So just some of the background there. Next slide, please. So this slide here just talks about some more numbers, and this is where how can we help the population to get more access to dentistry. As it stands at the moment across England, we are funded, or the government provide us with funding for essentially 50% of the population. So 50% of the population could access the dentist at any one time. That's the funding that we've got available to us. So how do we spread that out, and which 50% of the population do we actually use the money for is a real challenge. So these numbers on here are around the practices that are bringing back patients across the year that are low risk patients. So these are patients, quick wins, back to Matt's table there of 1 UDA, a quick count, do a checkup on a patient that's generally fit and well. Every 6 months means that they've added another UDA, but really in reality that patient doesn't actually need to come back every 6 months. Based on their oral health, based on their physical health, they actually probably could come back every 12 months or even every 18 months, and if they did that, they would free up a further 2 appointments for other patients to attend. So these are numbers that we look at with our practices, and the sort of the run rate of our practices and how they're spending their dental budget, if you like, in terms of what patients they're bringing back on a regular basis. Next slide, please. So I'm sure most people have heard about the clawback. We tend to not use the word clawback now. We'd rather use the underperformance word. So this is where contracts start the beginning part of the year funded 100%. So a dental contract would be divided into numbers of UDAs multiplied by the price per UDA, and that's the allocation that practice gets. From the 1st of April, that amount is divided into 12 equal monthly instalments, and that's paid to the dentist. So essentially, if they continue to deliver on their target threshold is 96% before we start to look at reclaiming any money from a contract. If they continue to deliver at 96% each month, they will continue to receive their allocation of funding. The allocation of funding that they take has then a reduction made to it, which is the patient charge revenue. So if for those of you that have been to NHS dental practices and pay NHS dental fees, that's the sum that's made up. So is taken off the contractor. So they paid, it's hard to explain, paid a full amount and then it's deducted off the patient charge revenue. So that's the amount that the dentist actually gets. So actually from the NHS. So if practices underperform in a year, we have some key points in the year where we look at activity. So we have mid-year, which we're running through right now. We're still finishing off the year end, which was last year, as a carryover, and practices are still paying back some of the underperformance monies from the previous year. So in the 22-23 year, if they underperformed on their contract, we're still collecting money back from those practices, and we try to do that in a reasonable way, extending the payment terms out over, say, 6 months, for example, which hopefully doesn't affect the practice too much. We know the end of year activity in July, so we know how much we're going to get in terms of this clawback or this underperformance money, but it's never an exact number. But what it does do is by July it gives us an indication of what we've got coming back into the pot that we could potentially reinvest quite quickly into dentistry. This is what we call non-recurrent funding. So going back to the beginning part of the year when the contracts are issued on the first, or the contracts are from the 1st of April onwards, those are what we call recurrent. They are in perpetuity contracts, or they are contracts that potentially are 5 to 7 years in length. So that is the 100% of the funding that they receive. That is recurrent funding. The non-recurrent funding is something that we get that bounces up and down on a yearly basis, and that's based on the clawback or the underperformance number that we've got. So working with the ICB, we would absolutely recommend that what we do is we commission at risk, essentially, knowing that we're going to get clawback, knowing that contracts will underperform, knowing that there will be some money available in the pot. We could commit that money to spending in the short term on access initiatives, for example. In terms of this sort of the bullet point at the bottom there, which is changes in the commissioning. So if we focus our activity onto the patients that don't pay patient charge revenue, that actually will impact the finances, the overall budget numbers that is allocated to the ICB. The UDA rate is historical. There is no one UDA rate the same from practice to practice. In fact, you may have neighbouring practices that vary in value. That's a historical rate that was set in 2006 when the new contract came into play, and it was it was calculated based on what the practice did previously in terms of activity. So the idea was that the UDA value would not be detrimental to the finances of the practice, so that they would receive a similar amount of funding. So the UDA value is historical. However, it's a real challenge in practices where you have a low UDA rate, particularly hard to recruit dentists when the rate is quite low, because you've got to pay a dentist a reasonable amount of money to come and work in the practice. Next slide, please. So I think we touched already on the dental reform. So the South West Dental Reform Programme was set up in 2020, and this was really done as a programme to look at the issues and challenges that we've got across the Southwest with dental access. There was a lot of collaboration, a lot of workshops that went on, and people came out. The overall output of that was that we needed to focus on 3 key areas of work. So that access, workforce and oral health. And I think Rob's already said that this has been taken on into Dorset now as a continuation of this programme. What the dental reform team do is look at different ways of working with dental providers to be able to increase access for patients, different ways of looking at educating those dentists or enticing dentists to come and work in a region where perhaps they may not, or they may prefer to work in larger cities where there are bigger teaching hospitals, for example. So it's how can we all collaboratively work together to increase that workforce to come and work. And in the oral health arm, look specifically around those key oral health messages that we can deliver. And this is where the integration of the ICB comes in really, really well. So it's the integration with other healthcare providers. Delivery of key oral health messages doesn't have to be done by a dental health professional. It can be done with anybody. Anybody can learn a key oral health message, and they can share that key oral health message. So it's really key that there's some pieces of work that are being done around that. And next slide, please. So specifically, the dental reform programme is focused on the under 18s. I won't go into all of this, it's like a really busy slide, but just a few things that we've been doing already with the focus on the under 18s. We've got a programme that was underwritten by the Chief Dental Officer, and this is called Starting Well Core. This is where we're absolutely focusing on those 0 to 2-year-olds, and again, those key oral health messages, making sure that we get diet, good healthy habits put into the young children. And this is where dental practice nurses potentially and dentists go into healthcare facilities, working with community nurses, nurses, midwives, etc., to help deliver those key messages. First Dental Steps was a pilot in progress, and it's now been approved to extend across the whole of the Southwest. And this is where dental health professionals train health visitors in, again, providing those key oral health messages, but also supplying of toothbrushing packs, the right type of toothbrush for a small child, for example. And then when they're coming into contact with vulnerable children, they refer them through into the community dental service. So this would be our looked after children and our universal partnership children. Supervised toothbrushing, there was a pilot that has run for a number of years in Devon. That's now been extended out across the whole of the Southwest. Dorset is due to go live mid-November, which is absolutely brilliant. What this does is it focuses on the children that are in the most deprived schools. And it's an evidence-based programme of supervised toothbrushing where the school are taught how to, again, monitor toothbrushing and also deliver those messages as well. And in the school setting, the provider also supplies toothbrushes, toothpaste for the children. We recognise that in some deprived areas, the children aren't even having access to toothbrush and toothpaste. So they get a pack at school, and then they get a pack to take home for the long holidays as well, which is really, really good. And essentially, this is a programme that's then monitored and looked at. It's one of the only 2 interventions that is recommended that you can do to help prevent longer term tooth decay for children, and hopefully the outcome of this will be preventing children from going into the hospitals to have general anaesthetics to have teeth extracted at a later date. We've also had a child focused dental practice running, so there was one in Corfmullen. Really proactive practice where they were taking referrals from dentists that had children that had slightly more complex dental needs, and that they actually couldn't, so they needed to enhance skills to actually be able to help and support some of those children. And again, this was an initiative to stop those children bouncing into the community sector and then onto secondary care for a general anaesthetic. And then the final bullet point at the bottom is about welfare checks. So this is where we took an adult model and adapted it, made it into a child-friendly model. And this was rolled out during COVID, but it's a continuation now where we continually review the waiting children that are waiting on a list to constantly see that they are okay, nothing's changed with them, they don't need to be escalated up the list any faster to be seen or treated any further. And the welfare checks go on all the time. Next slide, please. Stabilisation is another piece of work that's currently underway. So this was again looking at a slightly different way of doing things. And as we came out of the pandemic, we did some research to find out what dentists how could we encourage more dentists to work on NHS patients. One of the things that we did was look at stabilisation by a sessional rate, and the national team set a sessional rate for some urgent care post-pandemic, and this is something that we've taken on. So a practice will get paid a certain amount of money to treat patients. This allows them more time, more flexibility to actually get a permanent resolution for a patient rather than just going in and say, just for example, having a tooth taken out. So the stabilisation pilot's been really successful. We're just waiting for the output of the report on that, and we are looking to commission that further going forward for longer term contracts. Next slide, please. Oh, I think that's me done. So it's back to Robert now. Thank you.
Chair, I realise we might be running over time, so are we okay? Okay, I'll be brief. Tess, thanks for that. It might be worth just flagging up as well, Tess, that I know that you working with health overview committees across South West, you're looking to develop an offer around a webinar for those that might be interested in going into more detail around the dental contract. Is that right?
Yeah, so essentially we're looking at doing a masterclass. So we've tried and piloted this in Devon, but we're now looking at extending this across so that all Health Overview and Scrutiny Committee members could log into that as a webinar type setup so they can understand more about dental contracting.
So we'd be happy, Chair, to get details of that to you if members are interested. Thank you. I just flagged that up as well because we realise this is complex. So I'm just going to summarise and try to keep it simple, I suppose, really, at this point. The current contract is complex. Dentists don't like it, generally, and dentists are leaving the NHS contract. Quite considerable numbers in Dorset, but I understand other areas are even worse than ours. So this isn't a problem, sadly, that's going to go away anytime soon. What Matt and I and others have learned from taking on the general practice delegated responsibilities some years ago now is the number one important thing is building relationships. I said at the start, I'm going to say it again now. We need to build the relationships. We need to make sure those dentists are feeling valued. Important conversation in this committee earlier about the safeguarding staff feeling valued. The dental staff, a lot of them are not feeling valued. Tess and I joined a call last week where the dentists on the call were actually visibly upset on the call about struggling with managing patient expectations. So sadly, our media paints a very different story about, maybe dentists just being in it for the money and not wanting NHS contracts. We know, meeting with dentists, they are really passionate about providing NHS care, but at the moment, the contract on offer is not sustainable in terms of a business model, really. So we're having some really open and honest conversations, and I think it's really important that we do that. Tess also mentioned, and I learnt this for the first time when we took delegated responsibility, and I was quite shocked by this. I don't know if members of this committee realise this, but we've only ever been funded for 50% of the population to have access to NHS dental care. So that was quite a sort of, wake-up point for me, and I'm sure it will be for others, that, if we do increase our access to NHS dentistry, there's going to come a tipping point where the government money is going to run out. So that's why I said to you earlier about the importance of oral health and prevention, and that's why that work with children is so important, because if we continue with our current profile of oral health, the colleague earlier as well mentioning around the use of the DICE system, we know that our projections are that dental caries and dental health is sadly getting worse, certainly in our deprived populations. We've got to turn that tide if we're going to do anything about it. The other statistic we heard recently, and I think Matt will correct me if I got this wrong, but I think it's 50% of dental graduates reside within the M25. Is that right, Matt?
The statistic is that there's 50% of all...
Sorry.
Okay. 50% of all dental professionals reside within the M25 corridor for England, which is an awful statistic for those of us that are outside of the home counties.
So thank you, Matt. So the other conversation we're having is, can we develop a dental school in Dorset? So we've just started those conversations now. That's going to take a number of years, but that should be our ambition about how we can, encourage dentists to come and train and develop and come and work in Dorset and stay in Dorset and really sort of do that. Our dental schools are too far away, we would say, really, and we need to have some dental school activity within our sort of county area, really. You heard a lot about from Tess around trying to return to pre-pandemic levels, and that's a government priority. Our general practitioners, despite the press and the sort of media and everything else, in Dorset, our GPs are now above their pre-pandemic levels in terms of activity, but our behaviours as members of public about what our expectations are. We're very consumerist in demanding care, and therefore GPs have seen increasing demand, and so therefore, although they've increased their access, the public are not seeing that really because the demand's just gone up. And that was important what Tess was saying, because we're invited, a lot of us are still invited back if we have got an NHS dentist or if we've got a private dentist, we'll be invited back every 3 or 6 months. The evidence base is that we don't, if we've got low risk, we don't need to be seen that often. And the trouble is, if we're seen that often, then it's somebody else needing that care who can't be seen. Now, that's a really big piece of work about how we work with patients and public about understanding demand and capacity. So again, lots of work to do with our colleagues in comms and engagement and Health Watch and others about understanding that. The final point I wanted to make before I come on to, the summary slides come down, but I'll talk to it anyway. The final point I wanted to make is we don't want to continue long-term with commissioning units of dental activity because we believe that's like buying widgets rather than buying outcomes. So we're buying activity, but if the activity goes up, at some point we're going to run out of money to buy the activity, and it's not actually directly related to outcomes. So what we want to do is look to a commissioning model where we're working with dentists around population health outcomes. Now that's going to take some time, but the government is listening to us and others now about our view on this, and there is some contract changes coming in and flexibilities on the way in which commission services for the future. So we're we're hopeful now that we'll be able to start working with dentists in a different way moving forward. The last slide was really just summarising what our priorities are, and they are around oral health, the dental workforce and dental access. And, as I said earlier, part of that is really about building our relationship with the dentists and the dental leaders, because we want to work together. We want them to feel part of our integrated care system, and we want to look together about how we improve access and oral health moving forward. Thank you, and happy to take questions.
Phew. Thank you very much for all the presentations. I have to say I found some of those statistics truly shocking. I'm just blown away at the moment. Funding for 50% of the population just isn't acceptable. Yeah. And I suspect that isn't widely known at all. Can we go out for questions? I think I've got Councillor Orrell, please. Yeah.
Thank you, Chair. John Orrell, Melcombe Regis. Interesting presentation. It's clear you're doing the best you can in very difficult circumstances. Lots of workarounds and trying to spread the limited money so it's spent most effectively. Thank you for your candid appraisal at the end of the summary. It's very useful to get that context of the 50% funding, which was shocking, and the problems with the contract as it's currently nationally configured. It's clear that this isn't a Dorset failing, because you've shown us the figures across the Southwest. So this is a national issue. I've spoken to dentists, and as you say, a lot of them are going into private work reluctantly. They actually want to deliver good dental health to their poorer population, but can't because of the way the contract is set up, and they just cannot afford it. So you hinted at the end about flexibility in the contract, and that we've got these commission services which aren't being delivered. Is there enough flexibility within the Dorset, if we take back this commissioning, to take that pot of money and redesign a Dorset contract for dentists so that our dentists are properly and fairly remunerated for their NHS work? That would mean going against the national contract. Can we do that? And the second one is making us attractive to people outside the M25. The recurring theme we've talk about in this committee is housing. If we came up with heavily subsidised housing, would we attract the dentists?
Yeah, thank you, Councillor, for those. I think, first of all, the short answer is yes. I think the government and NHS England are listening to the concerns of ICBs and are introducing greater flexibilities in the way in which we will be able to commission the contract moving forward. I think my reflection would be, though, is where we find ourselves right now is going to take a lot of effort and a long time, really, to get where we want to be. So I'm really keen that we build those relationships so that we're on that journey together, so that the dentists, work with us on this future. Right now, within the next year, what our ambitions is to start offering some population health contracts around dentists that we've just written to dentists very recently to offer this, around dentists that would be interested in working with us around some population health outcomes. So it would be an outcome-based model of a contract. In terms of that national steer around the units of dental activity, I think what we're looking to do is attribute the value of that contract to the value of the UDAs, but make sure that funding is at a level that would allow the dentist to be able to deliver that care in a way in which that is a sustainable model, really. So we're not giving up on UDAs, but we don't want it all to be about chasing UDA units of dental activity. We want it to be around having that meaningful engagement with our dentists and our dental clinical leaders around how we work together on population outcomes. And they are very receptive to that, and they are very thankful to us for having that conversation locally, because in their words, they've not had this conversation with anybody for the last 10 years.
Is that okay? Thank you very much for that. If I can bring in Councillor Kimber, please.
Thank you, Chair. Councillor Paul Kimber, Portland Ward. One of my previous dentists on Portland warned me some years ago that we was going into an iceberg if we didn't do something about our dentistry. And what worries me from your presentation, and thank you for your presentation, it was upfront, it was honest, and I know we've now got real problems that we've got to deal with, not only for us as councillors, but politically, and that goes right across all the parties. And I say that because I'm lucky enough to represent a ward that does have serious financial concerns on Portland, and I know the dentist, who's a fantastic guy we got on Portland, but we don't have an NHS or very much NHS capacity. Now, particularly for an area that has a large deprivation, we do need an NHS backup. Now, you've given us some ideas today that we should have a dental school in Dorset, and I wondered if Chair, whether we can take this out and look at some of the recommendations and really press home with some of the aspects you said. I can't really ask you a question, but it's really just a point I'm making that, boy, do we need a real think about, and we need the government to really help us. And that was an awful stat that you said that half the dentists are in the inner M25. Well, that again, something has got to be done there as well. That you can't just desert communities like this. And as you said, that dentists are beginning to pack up, move on, and I can understand their frustration. We all want to do a job that we get us an element of satisfaction, and we know that we're doing good. Thank you, Chair. That's just a point. It's not a question. Sorry about that.
Thank you very much. I don't know whether you want to comment or you would. Okay.
Yeah, just to say that we've written to dentists. We want to speak to dentists. So if you're aware, if you're in any communications with dentists, we want to speak to them. We want to work with dentists throughout the future. And we particularly want to look at how we could support people living in areas of high deprivation, where we know that there's likely to be oral health inequality as well.
Thank you. Can I go to Councillor Cook, please, first?
Thank you, Chairman. Councillor Robin Cook, Stour and Allen Vale Ward. Yeah, thanks for the report, folks. It's very interesting, and it's doesn't make very good reading. I don't mean it's the way it's written, but it's just the news in it. We looked at, was it about a year ago? We were here doing a similar exercise, and it's actually a more gloomier picture. There's still the same message coming through on a lot of these, and I think John Orrell did touch on it. The issue in Dorset is still going to be housing and attracting people here, and I'm not going to go into that anymore. We all know about that. I noticed that in the report it suggested that the council does, can I put it this way, Dorset Council does more in promoting Dorset to attract those people within the M25 to come down here. Well, I don't quite know how much more of that we do, because Dorset, to some extent, promotes itself because of the type of county. It's a double whammy, because you've got the young people who are coming into the profession, and there are less of them, as I see it here, who don't want to take the rural life. They want to be in the big city, the big lights, near the big lights, despite the ULEZ zone. And sorry. And I can see that. As somebody at that age wanted to be in the bright lights as well. And when you reach this age, you want to be in the more rural, so I can understand that. Waiting lists come up every time on these. Dentists got, in my area, we've got quite a few practices because I'm on the east of the county, so we've got quite a plethora of dentists there. But I don't think there's any NHS vacancies just now, but there are plenty of waiting lists which are open-ended. There is a question coming, Chairman, by the way. Yeah, this may not be an answer to this because it's one I think I've raised previously. How much can be done? Is there any method of people that have managed to get an NHS dentist some years ago and are still hanging on to that when they could in fact be going private? So Molly's waving because she probably remembers me asking that question. But that's one, and I don't know, because I think there's a hidden number, quite a hidden number there, people that could. That's one area I think maybe we could tackle and free up some space quickly, notwithstanding what you've said, the plans for the long term, which are eminent plans, really, very good. But what can we do now?
I have some very radical ideas, and we're starting to talk about them. I think we've got to be brave enough to think about the public-private mix moving forward. Now, I've been in the NHS, working in the NHS over 30 years, so, you know, cut me in half, you've got NHS written there. So I find this really difficult conversation, to be honest. But I think the reality is, if we don't do something radical, then we are going to lose people from the NHS part of the profession, as it were, really. And these are dentists that want to work for the NHS. I think there is something to be done there. Now, I don't know whether, you know, somebody would be willing to give up their NHS place for somebody more needy. I mean, I don't know whether you were going there with that, with that question. But I think what we could look at is in the private dental world, there's these dental plans that people, you know, sign up to. I'm wondering, and I proposed it as a question across the Southwest, whether we could develop a plan where we would fund dental plans. Now, clearly we couldn't do that for the whole population, but maybe we can do something for those in greater need of dental access or health support. So that's something that we are looking at.
That was a really interesting question. Altruism is great, isn't it, when it works? But getting people to give up their NHS contracts when they've had them for years and they don't have to pay for them. It's not as if they can go from one dentist to another. It's, yeah, how you actually do that. Because that was along the questions I was going to ask when it comes to children and people who come into a group that need additional dentistry, such as people who are pregnant, people who are young children. You're doing a lot of preventative work, but there's still a cohort of children who probably never get checkups because they're not an NHS dentist and their parents can't afford to buy the dentistry care that they need. Sorry, I'm just jumping in and asking a question, and I do apologise, I'll come to you in a moment. Have you got any statistics around people who need dentistry help, who are basically struggling with the cost of living and all the other costs that we're all struggling from at the moment and cannot afford to go to a dentist? I have a friend of my daughter who operates in Taunton Hospital, about the amount of children that she has coming in, almost on a conveyor belt, where the children haven't had access to dentistry because their parents are unable to afford the dentistry care that child probably needed a couple of years ago that would have prevented the child then needing an operation. I don't know whether you've got any statistics around that, because it's all about longer term type prevention and stopping some of these children ending up having to have operations to have teeth removed that could have been stopped had you been able to get there in time. And I do apologise for jumping in on your question.
Yeah, I'll take that one. So in short answer, no. There's no specific information that we have that shows what that looks like, particularly in paediatrics or younger people. What we do have, though, is a lot of unknowns. So the information that we provided today shows those that are accessing NHS services. What we don't know and what we would like to see overlaid is those that are forward and going to pay for private dentistry. So there's an element of our communities that will that can afford and will go for that. But there's then the element of the unknown people who are not accessing at all NHS or private. So going back to the DICE information and the data that we have, as now, you know, we've taken more responsibility for dentistry, what we'd like to see is that overlaid, that real patient information around who's accessing, who's not accessing, what parts of the population are, particularly those in deprived communities. And we've heard on all of our presentations today, the people in those communities are often ending up having the teeth pulled. What we do know in Dorset is that we have seen an increase markedly in those children requiring surgery under general anaesthetic, which is really, really sad. And we've already pledged additional funding this year to ensure that that waiting list comes down. And we had more than 400 children waiting for a general anaesthetic for surgery at Dorchester Hospital. So that will come down and that will be reduced by over the next 6 to 12 months. But one of the things we'd like to do is improve that data set to ensure that we are, you know, those in those communities are accessing at the right time. And perhaps, you know, we do need to be radical here. We do look at those deprivation areas, those, you know, those in deciles 1 to 6, for example, and really target some of those outcomes rather than bean counting like we are at the moment.
That was really interesting. It's the fact that you're bean counting rather than treating, and it's outcomes that are the important. But okay, I've got what's her name?
Tessa.
Sorry, I've got Tessa wanting to come in online. Can I just go over to you?
It was just to come back on the point about the private dentistry side of things and who gets the 50%. And I think that's what I was trying to allude to in the slide when I was delivering the message about the 50%. Who is the 50% of the population that gets dental care? And it's an interesting one because we've just started a pilot in Cornwall, because I look after the contracts in Cornwall as well. Started a pilot in Cornwall, and it had to be run in collaboration with so many stakeholders to deliver the right message, so that when it landed, that these patients that are frequent attenders, that are frequently what we call the walking well, if you like, the patients that potentially could go private, when they were taken out of the practice in favour of those patients that were in the more deprived areas, the children, the patients that had health conditions that determined that dentistry was really important to them, such as pregnancy, cancer patients, diabetic patients, for example. So when the practice made that shift into those patients, that message was delivered with a very big stakeholder brief, which was along the lines of, you know, we're doing this and trialing this. We understand you may be put out, that you can't get access to dental care, but actually this is the reason why we're doing this. And, you know, and when you deliver the message properly, I think, you know, what we're saying is that we are trying to tackle those health inequalities from that perspective. And the subliminal message, I guess, is if you can afford to go private, go private. But, you know, that's just something that we've been trialling in Cornwall.
Thank you. That's really interesting. Can I go to Councillor Brown, please? And thank you for allowing me to interrupt.
Not a problem, Chair. If it's okay, I just wanted to drill down into that 50% figure, because to me, I think there's two parts to this. There's the macro picture and there's the micro picture. So the macro picture is setting people's individual actions. And please correct me if you disagree. So you said, you note that there is 50% of the dental need is funded through the NHS. Does that currently include the funding that the private individual pays? So, you know, when you have a sick monthly checkup, you pay about £30, don't you? Does that include that portion of it, or is that excluding that as a start? That's my first question.
Probably
Want me to come in on that one?
It's probably best to go to our colleague Tess.
Yeah. So just it's sort of terminology. So it's not funding 50% of the dental need. It's funding 50% of the population. So if you look at it that way, 50% of the population may at any one time not necessarily need their checkup every 6 months. So, but some in another part of the population, there may be somebody that's got a higher need. So does that answer the first part of the question around the fact that it's not the need that's funded, it's the population numbers that are funded for? And there was a second part to the question, I think, about the routine examination you were going on to say.
Sort of. I'm trying to understand what does that look like? You say it's 50% of the people that are funded, irrespective of what they use. How?
Yeah. There are measures. Essentially, I mean, when we buy dental contracts, if you like, we would buy dental contracts based on an indicative average of numbers of these widgets, units of dental activity, that a patient might be likely to use in a 12-month period. So we would normally say you would divide it by 3. So you would normally say you can issue a contract of 9,000 UDAs. You would expect to see 3,000 patients for that 9,000 UDAs. Yeah.
Okay, and so your budget is provided effectively in UDAs from central government?
Absolutely.
Okay.
It's provided absolutely. It as UDAs from day one, and they have a target from the 1st of April. They then have a target through to the rest of the year of the minimum level target they're looking at is 96%. But you can see that we're already projecting at this point in the year only a 66% delivery for year end. That's what we're predicting now. Now, it does go up and down. There are seasonal variances. We know that. We know that lots of dentists go on holiday over Christmas. We know that changes. So by the year end, I'd expect to see that 66% pick up. But looking at the historic data, the historic activity, we're not going to get anywhere back to that 91% it was in 17-18. That's just not going to happen this year.
Okay, and I think that would probably strike everyone in this room as a surprise, and everyone out in the general public as well. And picking up on the sort of point that Robin was making in terms of that self-funding versus NHS funding, what I am aware of people that hold on to an NHS place, some of which, who travel multiple hours drive to have their 6-monthly, whatever, annual checkup, solely so they have that option available if they ever require more extensive work. If you want to look to go down the route of encouraging more people to go private, which actually I think is probably quite uneasy for a lot of people when they think of how the NHS should be in terms of free at the point of use, how can you look to put a structure in place that still allows those individuals to access more expensive and more complex care through the NHS if you want to try and move maybe their annual checkup appointment into the private sector?
So any patient that access, whether it's private or NHS, if they need advanced care, either in community or secondary care setting, would all become NHS patients. So as they require slightly more advanced, consultant-led or specialist-led services, that would be provided still in the secondary care setting. So the routine care, as you were suggesting, could be examinations, could be dental examinations, could be done in private. But it's when you get to that point of how do you split off a filling, for example. So where would the filling be done, and what would the cost be of that filling that gets done? It's quite complex, and there's also certain rules, and whilst we are, and it's really enjoyable working with Dorset, I have to say, because they're one of the most foresighted ICBs about how can we flex this and make this different, and I think that's really exciting. But we still have a contract that is underpinning what they're paid. We still have standing financial instructions that our dentists are paid. There's still the Dentist Act. There's still all of those underpinning documents that we've still got to work within to keep our contractors safe from a legislative point of view as well. So we can flex and bend, but one of those key flexes and bends is you cannot mix treatment on one patient. You cannot start an NHS course of treatment and then suddenly deviate into, I'm going to provide that filling for you privately on the same tooth that you might have done an NHS, I don't know, something on, for example. So you can start to drill the tooth under the NHS and then fill it privately. You're not allowed to do that. Not allowed to do that. It's called mixing. It's very, very difficult, very complex.
Sorry, can I come in? What we're starting to debate is a bigger debate, isn't it? It's about the future of what is universal services versus means tested, the public-private mix and everything else. It's a really important debate, but I think it's a bigger debate because people are also having a debate about the future of general practice, which has always been a universal service. We know other countries where you've got to pay to see a GP. Now, I'm not suggesting we're going there, but that debate has started within our society, isn't it? So I think there is a bigger debate here. What we're trying to do right now is make sense of with the funding we've got, how do we try to improve access to dental care and, really importantly, oral health? Because if we're looking long term at this, the only way we're ever going to have enough funding for dental access is if we tackle oral health. So I want to make sure that we don't disassociate the two, because I think it's really important. And the oral health bit is the bit that we really need to work together on, is around the future oral health within our sort of public health. But let's work on that alongside. But I don't want that to be lost, because, as I say, if we don't do the oral health improvement work, which we're doing with your public health colleagues, then we're really never going to be in a position to be able to fund dental access. Thanks.
Okay, well, I do believe it actually is quite important. And when you're looking at how you build that set of contracts in the future, that will have an impact on it. Because I think we need to be very clear. You have to currently pay to access preventative dental care in this country. You know, even if you're on an NHS dentist, and, you know, we all have our opinions on that. Mine is that you shouldn't have to pay for that. But, you know, one last question. I was just wondering if you could provide a quick update on the state of out-of-hour emergency dental accessibility in Dorset, because the feedback that I receive as a ward member is that it verges on non-existent, on out-of-hours kind of stuff. And I recently had someone who had to go all the way to Basingstoke to access a dentist, which, again, is fortunate if you have a car, but if you don't, which a lot of our more deprived communities and deprived more vulnerable residents don't, that again becomes a bit of a challenge as well. So I was hoping you could give a quick 2-minute update on that. Thank you.
So we'll ask Tess to come in here, because it's a part of a wider piece of work around the dental reforms and urgent dental access. But one of the things that we're looking at doing, and Tess may be able to give more information on it, is we're trying to see how we can engage our dentists in trying to tackle that issue around urgent dental access. I think there's two things here. There's one about, you know, the number of appointments available, but there's another thing about how do we reduce those requiring urgent dental care. And the important thing there, which we'd like to do more on, is this stabilisation pathway that Tess referred to in the presentation. And that's where those with a complex dental need have a whole treatment program to try to stabilise their condition, really. Because at the moment, those patients are more likely to go in and out of trying to access urgent dental care. So if we can do more stabilisation work, but alongside that, I do recognise that we also do need to try to make sure that there are more access to urgent dental appointments as well. Tess, have you got any further information from the regional work on that?
Yeah, so across Dorset you have a dental helpline which is in operation, and that's staffed by what we call General Dental Council registrants. That's dental nurses, hygienists, dentists, therapists that provide appropriate clinical advice to patients when they contact. The other focus of that helpline is to place patients into urgent care dental appointments that we've commissioned as slots in high street dentistry, if you like. In terms of the out of hours, just defer back to the council that just asked the question. Interesting to know whether that was a night time or was it at the weekend, because obviously there are limited slots available out of what we would call normal surgery hours, which are 9 to 5. Over the weekends and bank holidays, we always stand up additional urgent care slots with our provider, because we recognise that's a problem for the bank holidays and the, you know, certainly over the Christmas period, etc. We'd be looking to put more slots available. So I'm sorry to hear that the patient had to go to Basingstoke. I think that the triage pathway that the helpline use as well is that they use it based on disposition. So essentially, depending on what the patient is telling that helpline person as to how quickly they would recommend they needed an appointment. Unfortunately, some of those patients do obviously end up in A&E because it's clinically appropriate for them to go to A&E, but some of them will have to wait till the next morning till they get a dental slot.
Is that okay? Okay, thank you. Can I go to Councillor Ireland, please?
Yeah, Councillor Nick Ireland, Crossways Ward. A very simple question, I hope. So it's now 7 months since you took over commissioning an NHS Dorset. Is there yet a demonstrable impact of that change? And if so, what is it?
Yeah, I'm bordering on between yes and no, really, to be honest, because the size of the issue, size of the problem. I think what we've started the conversation locally with dentists. We've drawn in some capacity and subject matter expertise from the regional team to try to support us. So we have made a start. We have commissioned, as I said earlier, the Health Watch work, which was part of that understanding the need and the unmet need. We've been working with Jane Horn from the Public Health team. We've agreed some work around epidemiology studies to understand need as well. I understand that hasn't been done for years. So again, we're progressing that work with Public Health. You heard from Tess that we've got a supervised toothbrushing scheme that's going to be introduced in Dorset in the next few months for the first time that's been there. So these things are coming on stream. I think if your question is about access to high street dentistry, I think, no, we haven't been able to make significant inroads yet. I think it's just fortunate that perhaps the data is showing at the moment that there's been some improvement in the last year, because we know that this is a real challenge and this is our number one priority now, to look at that dental access. But as I say, we do need to be doing that long-term oral health work alongside it, because just working on dental access alone is not the answer to this problem.
Is that okay?
Can I just come in there? So where we do know we have let's call it underachievement within our practices, and there's some stats I gave you earlier that shows how many UDAs we commission versus how many are actually being performed. That underperformance is generally in our most deprived areas of the community. That is where we really want to start our focus. So as Rob alluded to earlier, some of our plans for the next 12 to 24 months is target those deprived areas, look at those outcome-based commissioning, and we are fortunate, as you'll see by this, that there is a bit of money available because of the underperformance, and we are looking at really radical options for commissioned dental services in those areas. And I'm not just saying it's just those areas of deprivation. We hear from a lot of dentists that it's people towards the end of their life and people in care home and nursing home settings that really have poor oral health as well. I mean, to speak to dentists, and they're the people they want to reconnect with and provide more domiciliary services too. So there's a lot in our plans around paediatrics, young children, young adults, those in deprived communities, but also those people towards the end of their life as well who shouldn't be suffering oral pain in those last months of their life. Thanks.
Thank you very much. Yeah, it's depressing. I perhaps am one of the lucky ones. I've got a dentist, and I actually managed to get an emergency appointment the day after I phoned. I think I must be one of the lucky ones. I might have this dentist in Dorchester that you say has emergency appointments available for people. But they do also, I think, what Tess called split, and they don't do the private work, but if you've got some of these specialists, they will send you elsewhere. Because I think so many people worry about private dentists. Maybe you end up having something done that you don't need done. But I really get this. Why are people expecting to see a dentist every 6 months? Because if the message was you don't need to go every 6 months, that actually surely would save so much time. And I think we as a nation are expecting that, because that's what we've been brought up with. And I think that's the quickest message that you could get out for all of us, not to go every 6 months. But it's going back to Piers' question as well. Is this part of this clawback? Does the dentist take people back every 6 months because it helps them meet their targets so they don't have some of their contract clawed back? I don't know if that... It all seems so complicated to me around this, and I think it's, as I said, it's an eye-opener. But what I'm really worried about is I'm not really worried about, but you mentioned this oral health and children and the work that you want to do within the school setting and within young people's services. I'm old enough, and I think there's lots of people in this room will remember school dentists. And that was where that work was done. And in fact, there's a building on our campus here that used to be the school dentist office. And that was just an amazing service. I'm going to say something that's going to be really awful here. How can we expect our children's social workers and our teachers, who are pushed to the absolute limit of their day's work, to do what you were talking about earlier on? You're smiling because I think you probably have already had that thought process. I don't think, if I just talk about our staff, they're pushed to their absolute limit. And if you're trying to do a visit to a family and you bring them back into that support and everything, and then you get a bit critical to them, saying, well, now I'm going to suggest to you, I know it wouldn't be as crude as this, but we talk about oral health and we give you a toothbrush and some toothpaste. How does that build a relationship up with that family that they're trying to do? I think there's more than this meeting that we need to explore what you're suggesting with us. And you're probably having these conversations with our directors of these services, but I could just see some of the families that I'm involved with, and they're wanting some help from other things. And if they start to feel, oh, I've not done what I should have done about my children's oral health, they maybe don't want to engage with the other services that we as a council are offering them. And that's not a criticism, because I think the school dentist is the best ever, because that's where we get that sort of help back. But I don't want to build a barrier up to that thought process. But if we could stop having all of us going every 6 months, if we can get a dentist, and we can get those appointments offered and start that work with the children, that feels to me where it is really needed. And the dentist should then be able to feel happier about the, I know it's like Tess doesn't like that word, clawback. That feels wrong as well. I wouldn't want to think I had to meet targets, or otherwise my income would be gone. I'm sorry, and maybe the people sitting behind you, I think I'm off on the wrong track anyway, but, oh no, okay.
I'll come in here. We'll bring Tess in, because I know that she's got, she's been very close to some of those. The reason I was smiling is because I remember biting the dentist's finger when I was at school, so that's what made me smile. But you are quite right that it's like, school nursing and the school nurse, and that is not available. And I think in some ways probably need to go back to that. But let's not talk about previous budgets and historical decisions around that. So, Tess, did you just want to come in there, talk about some of that the question around paediatrics?
Yeah, there was a few things, and there was and I was smiling as well, because I think there were so many things that the councillor was describing there that we've all talked about, haven't we? We've talked about mobile dental units for to get to those hard to reach groups, not just children. We've talked about it in terms of asylum seekers, homeless patients, those people that are really that find it really difficult to access dental. So it is something that we've been talking about to look at. I think in terms of I just want to go back to the 6 month checkup thing, the question there, and the reason I want to just defer back to that is that yes, absolutely, there is nice guidance about dental recall, and the nice guidance is really very clear. It's based on clinical need of that patient. So my husband is one of those really lucky people, never has a problem with his teeth and probably goes once every 3 years. I need to go every 6 months, but that's based on my clinical need. So this is where we need to be just clear. It's not a blanket, don't go every 6 months. It's based on what your dentist says is appropriate for you in terms of that clinical need. Your dentist might say come every 12 months, every 18 months, or come every 3. So that was that one. And yes, to your point, yes, they do the easy checkups to make up their numbers on UDAs. That's absolutely the case. And you will often find there'll be an uptick in March when we're heading towards the year end. So there'll be an uptick in activity in March where they're piling people in to get checkups done because they want to try and avoid that clawback situation. And that's not the best way to work. I think the other bit that I wanted to just talk about a little bit around the supervised toothbrushing and the health visitor part. So the health visitors already deliver key oral health messages. What the First Dental Steps does is actually train them to deliver it, to give them confidence to deliver those messages. So it's very, very clear in the messages that they're giving, and it actually just funds a sippy cup for drinking to stop children drinking out of a baby bottle, which is a known problem for dental decay. It provides toothbrushes and toothpaste, and it provides the toothbrush that's a big chunky toothbrush that a child can hold on to with a really big handle that says, actually, I can brush my teeth myself, and it's about learning. So that's the sort of thing that's provided, and I absolutely get your point about the schools, but really what we're doing in schools for the supervised toothbrushing is purely training the team there in the schools to oversee the children brushing their teeth once a day, every day. That's what we're asking them to do, and just to keep the toothbrushes in a safe, clean way, sterilise them, and then, as soon as the kids come in after lunchtime, they've had their lunch, they've had their play, they brush their teeth, and then they start their afternoon lessons. So again, it's just about sort of supporting those messages, really. In terms of delivery of the key oral health messages, I always refer to our patient engagement, the lady that used to work with NHS England, still does work with NHS England, and she learned a key oral health message, and that was spit, don't rinse. Now, she is not dental in any shape, form or way, but if you get her on any call, she will tell anybody, spit, don't rinse. It's a key oral health message, but it's just an example that all of us can actually spread key oral health messages. We don't have to have any professional qualifications to do that. So if we've got key oral health messages out there, then we can spread the news. But yeah, I'll be quiet now.
Share with you. Perhaps you should speak to West Dorset's MP. He's going to resolve the problem. I just happened to pick it up yesterday. He's pledged to lobby NHS Dorset and the government to improve and ease the strain on dental practice. So perhaps you should meet with Chris Loader just to lighten the mood.
Okay. Thank you very much. Are there any more questions from the committee? I think this has been an extremely, extremely good discussion this morning. I'd like to thank you very much for coming along to talk to us. It's been a real eye-opener. I read the paper and thought, okay, I've got a few questions. I've thrown all them out because they're totally irrelevant, because they're digging down into the detail when the detail is what you've presented to us today. Going forward, we've got two recommendations today. The first one is that we're asked to acknowledge the difficulties within dentistry, and I think we would all do that. From what we've heard today, I am quite, as I said earlier, I'm quite shocked by the scope of the difficulties there are within that service. As I said earlier, we picked it up just by complaints from our residents and also what you see on the telly and all the rest of it. But it's when you actually start digging down, you realise the scope of the problem and the depth of the problem. So certainly this committee will acknowledge that and acknowledge the work that you're doing to challenge that. The second recommendation that we've asked to look at is that Dorset colleagues are asked to note that improved access to dental care and consideration is given to how council working in partnership can market Dorset to healthcare professionals. And I think that is something that is really, really interesting. We work with dentistry anyway through public health and through the ICB. So we have got people in the right place to pick these things up. But it's how we actually do it wider within the council. And we had a discussion when this was last on our agenda about how comms can help, because as a council, we're committed to have Dorset as a place to live, work and play. So this actually fits in exactly with what our key aims are as a council, but how we actually embed the wider aims of the council and the wider needs of our residents is the challenge on this. And we also, from an economic development angle, need to get this right, because we need more dentists. We need these sort of people living in Dorset and working in Dorset. We need to be able to attract them out of the M25, but we also need to give them something to come here for. It's okay when we've got people coming with young children, but it's the other groups of dentists that we need to be attracting down here. And I think we're going to have to take that away with us and look at how we can do that. I can't just come up with solutions during a meeting. I think what would be useful, I don't want to keep dragging you into our meetings, but I think probably in a couple of years' time, there will be a new council in next May. So how many of us will be here next May? Next May is basically in the lap of the gods. But I think it would be really useful in a couple of years' time, particularly as you're talking about using the money that you've got to target deprived areas. What I didn't say earlier is that I'm the councillor for Westham. So, and along with my colleague, Councillor Kimber on Portland, and also Councillor Orrell in Melcombe, you've got basically 3 councillors from some of the most deprived wards in Dorset. So we are going to be very interested in tracking what you're doing and looking at the outcomes of what you're doing, rather than looking at just throwing money at it. It's the outcomes for our residents that I'm really interested in. So I think we probably don't need to vote on this, do we, George? No, we don't need to. Sorry, I just need to check so that I get this right for the minutes. So I think from here, if we take this away, I'll take this away and see what else we can do within this council to support the situation that you're in, particularly around the promotions that you want, and whether it's possible. I don't know whether it's possible for DC to be promoting your messages. We possibly can do it through the public health and also through health and wellbeing. And I'll probably talk to, I think, Councillor Brooks, who's at the back, as to how we can take these initiatives forward. So can I thank you for coming today?
Could I just say something? You did say something there at the beginning, that you would like us to take the message to our own personal dentists. You did ask that, and that might be something that, if we've got a dentist, we could maybe help with. It's small, but everybody in the room, if they've got a dentist.
If you are in communication with dentists, we've asked to speak with them. So if you can just reinforce that message, that would be really helpful. Thank you.
Okay, so if we can take that away, and if I can thank you for coming this morning, and you're very welcome to stay for the rest of the meeting, but if you would like to go, that will be totally acceptable. Okay, thank you very much. And we'll move on to the next item. We're on to the last item on the agenda, and thank you, David Bonner, for bearing with us, because we are running a little bit late at the moment, but I'm sure you will have probably found that last debate very interesting. Our next item is on the Scrutiny Performance Review, which is a quarterly review that we look at. We had a pre-meet on this, just for the members of the public. There is a huge amount of information on this, and to try and discuss this colossal amount of information within a committee meeting is almost impossible. We'd still be here at 6 o'clock, to be quite honest. So what we have done with this is have a pre-meet, and I'm going to ask the officer who, David Bonner, is going to introduce himself, and then we'll run through what we felt was necessary to bring to the attention of the committee.
Thank you very much, Chair. And good afternoon, committee. So my name is David Bonner. I'm the Service Manager for Business Intelligence and Performance. I have just shared my screen with the public-facing scrutiny dashboards. So hopefully you've had a chance to look through these. If I click on the monthly update button, we can see that there are, I pre-filtered this to the red metrics for the month. We can see there are a number of items that were flagging at the end of August as outside of where we would like them to be. In the pre-meet with committee members, a number of items were looked at, and 6 items were considered worthy of some further discussion. The first of those was around the net number of households in bed and breakfast for the month. As at the end of August, that has risen to 73. I just hover over our information there. You can see on the graph that that's a better position than where we were at this point last year, but a small uptake on the month prior to that. So I will pause at that point and hand back to the Chair for any comments.
Thank you. I don't know whether anyone has got any comments they would like to make on this one. It is quite concerning that we have got so many people still in B&B. Or whether there's any officer would like to make a comment on that at the moment. If I can go to Councillor Ireland initially.
Yeah, Councillor Ireland, Crossways Ward. I think when we had our pre-meet, this is the one I raised a point on, because it mentions we've got more capacity. So the implication is, given the fact we've got more capacity, yet the numbers are essentially the same, it means if we didn't have more capacity, we'd actually be worse off, and therefore, we're actually in the wrong trajectory, if that makes sense. The fact that we have more capacity is great, but the fact that we're still in the same position as we were means that we actually have essentially got worse.
Thank you. Would you like to comment, Andrew? Sorry.
Thank you. I mean, it's a complex topic, as you know. I'd actually feel that the position is actually improving, and I'm not quite sure I understand the point, Councillor Ireland, but I think they getting worse when the position of front door demand is significantly increased and our temporary accommodation numbers are slightly reducing, I'd see as good performance, which we can happily go forward in more detail if we need to. Certainly current figures has dipped below 300 for temporary people in temporary accommodation, and our figures of families in bed and breakfast has reduced to 3 when it was over 20 this time last year. So I think there are strong stories of good performance within these numbers, particularly, and you'll see from other metrics, the demand certainly at homelessness presentations has gone up significantly since again this time last year. So I'd defend the position of performance being strong, given those numbers. And as I say, the position of 73, I think the number, it's not in front of me now, is considering where we were at the peak of COVID, where that figure was about 150. I'd defend also the position of that being good performance. And there's many cases in the press, in the media, as you'll see, Hastings, Chelmsford, places like that, where these our performance stands up pretty well. Happy to say more, but I think that the headline in the dashboard, I think shows strong performance, but clearly more to do given the high demand.
Thank you. Is that okay, Councillor Ireland? Okay, thank you. If I can go back to Mr. Bonner now.
Thank you very much, Chair. So in a very much related metric, if we move to the next one, it is indeed the number of new cases of homelessness presenting in August, which has is flagged as a concern with a concerning direction of travel. Just put the graph on screen there. So the data was 378 at the end of August. So again, Chair, I will pass you back.
Thank you. Do I have questions on this? Are there anybody wanting to comment on it? We're raising it as a concern. Okay, I think this is one that we're just going to keep an eye on at the moment. We've pulled it out as something that we are worried about because of the direction of travel. But we're reasonably content that officers are addressing it at the moment. If I can go back to the update, thank you.
Thank you, Chair. And finally, on this topic, again in a related point, the number of care leavers in bed and breakfast accommodation in August was 3 against our target of 0. Again, I'll just put the graph up there. So we are higher at this point. Oh, sorry, no, apologies. At the same level this year as we were at this point last year. But as the graph shows, it is slightly sporadic in terms of direction of travel.
Okay, have we got any questions on this? What would we like to do? Would we like more information? Would we like to just keep an eye on this and just watch and just take a watching brief on this? I'm getting nods around the room. So I think this is of concern, but we'll have a watching brief on this one. Okay. Can I go back for the next one, please?
Yes, thank you very much, Chair. Okay, so we're halfway through the 6 items. The next one is the percentage of new children in care receiving their health assessment within 20 days. So there is some commentary there to show the reasoning behind the numbers. We have a target of 95%, but the percentage we're at the moment, back in August, was 25%. This does, of course, also rely on our NHS colleagues as well. So I'll pass back to the Chair.
Okay, can I ask if anyone would like to comment on that one? Councillor Orrell, please.
Yeah, thank you. Councillor Orrell, Melcombe Regis. So it probably reflects the difficulty of seeing a GP, doesn't it? So do we need to get other professionals to be doing their assessments rather than GPs?
Thank you, Councillor Orrell. Many of the assessments are done by others, and I think this performance, whilst it's really important we continue to track it, probably has been impacted by the significant increase in the number of unaccompanied asylum-seeking children that we've been taking into care in the last few months as a result of the National Transfer Scheme. And not all of those children are in our own geographical area, as we've discussed before. So seeing those children, ensuring they get that right, and clearly it's really important for those children to have an urgent health assessment because they may well come with unidentified physical health needs. It remains a really top priority for us. I think the conversation I've had with my colleagues in performance is that there are probably some other health performance indicators that we should bring as a kind of bundle rather than just this single one, but it is an important indicator. Having that initial sense of how well our children are. Clearly our children come into care come from one form of trauma or another. So those initial health assessments are really important to keep a focus on. But they do have a very tight timeline. We don't have so much of a problem we have a bit of a flexibility problem with the timelines for when children can have their assessments. We are driven, I was thinking earlier with the dentistry issue, we're driven by an absolute requirement to try and keep our children in school full time, as we'd all appreciate, and yet often medical appointments are one of the things that take our children out of school. So we need to kind of continue to try and keep that balance. So we have those difficulties. And foster carers who have to be in multiple places can find it very difficult to be able to meet an urgent, sudden appointment for a new arrival.
Thank you. I thought that was interesting what you just said about the need for additional metrics. Is this something that we're looking at the moment?
Yeah, we are, and David may want to talk about that, but I think this board would be really supported by having a wider range of metrics that are shared between ourselves and health to be able to be confident about how well the system's working.
Thank you. That is really, really useful because this very much feels like a blunt instrument that we're using, and to actually understand what is behind figures is really difficult. I don't know whether you want to comment on that at all, David.
Yes, thank you, Chair. So I can confirm we are having conversations with our health colleagues looking at metrics and trying to combine some data sets as part of a review of the scrutiny dashboards for this committee. So we do hope to get some additional health metrics into the reporting processes over coming months.
Thank you. If you need the help of the Scrutiny Committee with that, please let us know, won't you? Because it would be useful if we can see what metrics you're thinking about. Because I do find some of these very hard to get to understand what we're actually doing and how we're actually doing it. And I'm sure the rest of the committee probably would agree with that. If we can move on to the next area of concern.
Thank you, Chair. Okay, so staying with the Children's Directorate, moving into the field of education, the next item flagged by the committee was around the number of special educational needs or SEND tribunals against the authority. We have a target of 5 in a month for that one. Back in August, we were at 12. I just hover over the graph there. Again, you can see that we are, in August, we were higher than at the same point last year, but the numbers do tend to fluctuate somewhat.
Okay, thank you very much. I've got a question. Do you want to ask that?
I'm sorry I wasn't able to attend the meeting. Is it because they're unable to get an assessment that we're looking at? Yeah, thank you.
Thank you. No, so the tribunal would usually be, in almost all circumstances, where we have recommended a particular setting, a particular school place, and a parent wants an alternative offer. And at that point where we think what we've offered can meet needs, and as you'd appreciate, may well be more local, and it may well be at a more manageable cost. Sometimes families may well choose to look to another independent placement, and the level of tribunal is slightly higher than elsewhere. We are encouraged by Central to have higher levels of tribunal to challenge that requirement for having a preference place. We look very closely at making sure that what we're offering the child can meet their needs, but we will withstand the initial challenge if it doesn't. However, as is well understood across the country, most tribunals are successful to the parent.
That must make working really, really difficult and challenging. I don't expect you to comment on that. Thank you. Could we go on for I think it's probably the last one, is it? Or the last but one?
It is. Thank you, Chair. So the final area for consideration was around the number of staff non-reportable accidents within schools, and in particular in children's services, in particular the committee was interested in the 21 violence actual noted in the commentary.
Thank you. Have I got a response to that one? Yeah. Okay, thank you.
Yes, thank you, Chair. I'll be very mindful in my response, and the numbers of children in the Cherries is presently very small, but those children have very complex needs, and the staff that work with those children, I think is it published yet? I think it's published. We've just had a most recent, it's not, we've just had a most recent Ofsted inspection, which I've just been reliably informed isn't yet published, so I can't say what that is. But fundamentally, I can certainly say that they accepted and saw exactly what we see, which is incredible care for the children there. And sometimes caring for those children with really complex needs does sadly involve some injuries to staff in part of that care when children's behaviours can be very challenging. We look at all of those reports all the time at the JCG with our union colleagues, and we take constant consideration of whether there's any matters to learn or reflect on from that. But the reality is some of the behaviours that young people express around biting or hair pulling meet the criteria as defined by public safety as violent. The intention may well not be that. It's simply a communication of a behaviour.
Can I just ask, do you think there's an element of underreporting of that? Because certainly within health and safety, I always feel there's quite an element of an underreporting. And it was interesting on the safeguarding board where numbers of reports are going up, which is good. It can obviously often be perceived as a as a bad thing for numbers to be increasing, but it's actually the reporting that is increasing. And I was just wondering whether there's any sort of feeling about underreporting of this.
Again, I'm not at all. In fact, Ofsted have been very positive about the way in which things are reported, recorded and learnt from, and that they can see that as a daily record. That's a really thorough process. So I think from our care point of view and from our schools point of view, we see that working really well. Interestingly, from the schools point of view, where we can see therapeutic work going on in our special schools, and it's probably for a longer conversation, but that sort of therapeutic intervention work has cut the number of incidents of attack or harm to staff or other children dramatically. And so it's a way of working, therapeutic thinking, which we're going to be rolling out across all of our schools. It supports children being protected well, but it works in other ways other than restraint. And obviously it's often in times of restraint when people get injured in particular. So we can already see, and we've been watching that very carefully, and therefore rolling out further, that therapeutic thinking way of working in our special schools has really dramatically cut the number of times people, children or adults, are injured.
That is very reassuring. Do any of the other committee members have any comments to make on that one? Councillor Ridout.
Thank you, Chairman. Linda Ridout, Gillingham. I think what you're saying there, Teresa, is important, that to have that therapeutic prevention work, because to keep staff, to keep your workforce, because if they go into a place where they're going to be, you know, it is stress, isn't it? So I think, yeah, that's a very important act. Yeah, thank you.
Okay, so I think the response from the committee will keep an eye on that one as well. So I think that is the end of those. Can I just ask if there are any committee members who've got any other items that they'd like to bring up from the dashboard, please? Silence. That's good. So could I just thank David for the work that he does on the dashboard? I think it's really useful. As I said, it does need some more refinement, I think is probably the better word for it. Because I think at the moment it's something that the committee is quite struggling with because of the sheer size of it. So thank you for your support and thank you for your help with it, and thank you for all the officers who've contributed. And thank you for, basically, because I think some of you hadn't had time to prepare for the questions you were given, and I do appreciate the answers that you've given. So I think we are just about at the end of the meeting. Oh no, we've got committee work plan, the forward plan.
Don't forget, you've got
Don't forget what?
No, you've got the work plan.
Right, we've got our own work plan, which we are fairly light on December's, but I'm fairly sure there is a possibility of 2 further items that could be added that will make it possibly quite a long meeting because they are quite chunky items. And then in January, we've got the budget strategies. So we've got another meeting on the budget, I think at the beginning of December. So I would encourage all of us to come to that meeting with a scrutiny hat on to go forward. And then we've got the last meeting of this council, which will be in March. There will be other work being done in the background of this committee. As I said earlier, I think a lot of our work is possibly better done in informal working groups and then reporting back to this committee. And there could well be some other work that is coming up within the next couple of months. So please keep your eyes open and please take part in all of the working groups where you've got an interest and where you've got time and capacity to take that on. So we've got has anybody got any comments on the Cabinet Forward Plan and also the Shareholder Forward Plan that I've explained why that was attached to our minutes, our agenda today? So there's no other comments. So there is no exempt business. So if I can call an end to this meeting and thank everybody for attending today. I thank all the officers and all of the councillors who've taken their time to come. Thank you.